medical equipment is one of the 6 fundamental pillars of the health system. And this underinvestment, what has it resulted in? Firstly, a lack of infrastructure and equipment, so the engineers are just not able to do their jobs appropriately. There's a lack of data and visibility for performance management, and where there's lack of visibility, there's a lack of accountability. And thirdly, there's not a focus on training and development on engineering, and specifically biomedical engineering. So I'm going to pass over to Masanja now to share with you in more detail the model that was implemented for Bugando.
Now, that's where now begins the facility operations. The vision for Bugando is to have the site that is saved by a skilled and a competent health providers. And historically, biomedical lacks competent and skilled staff. Most of our hospitals are saved by electrical engineers, electronic engineers, telecommunication engineers. So to save now, to have the skilled, that's where now Touch Foundation came in to support this vision in which it aimed to make Bugando Medical Center the center of excellence, not only in Tanzania, but in Africa. That's where now the collaboration have to bring in experts in biomedical engineering from US, from Germany, from Netherlands, who worked with us, testing the individuals, identifying the gaps, then tailor-making the training. To that, together we now identified focuses in order to reach the center of excellence. And the focuses one is the engineering best practices, the culture of performance measurement. If I ask you, my friends here, which facility, which organization are doing performance measurements, definitely they are very few if they are there. So what we did at Bugando, we identified the key performance areas for an engineer. When you come from home, what are you going to do? How are you measured? This creates the morale. We did the review of the job descriptions to have the roles and the responsibility clearly explained. What does the biomedical engineer do? What does the biomedical technician does? Another focus was the critical systems and the processes. Without having systems, with process that will show exactly, that will make the management have an informed decision, you cannot reach the center of excellence, which always we say that this is impossible in Africa. But myself, I can be a witness. I was taken from the private institute, from Tanzania breweries, where I was the manufacturing development manager, and we managed to make Mwanza breweries to be number 7 in the global beer industry. So it's possible. And that's what now we are practicing at Bugando and training. That's why I say that using the people from USA, from Netherlands, from Germany, identifying the gaps and tailor-making the training to biomedical staff at Bugando Medical Center Engineering. That's when we have been able to assess properly, to tell the management that this is that, this don't do this. And another approach now, which was our focus, was the innovative structure. You cannot work as if you are in a den. I've seen, I think, the first photo there, if you don't mind. This was a workshop for medical engineers. Do you think people are being motivated to work from that? It's very difficult, because this means that we are not caring, because it's natural. We care about nurses, about doctors, about medical engineers. We just buy the equipment, use it, fails, and throw it. How much money is lost over the country? That's where now we decided now to build from the Bugando management a state-of-the-art workshop that is all glass. When the head of the party is sitting here, can you see biomedical engineers what they're doing? If you come in there, we see that this equipment are waiting for maintenance. This equipment are ready and just to be taken by the doctors and the nurses, and this equipment are waiting for the payments. That's what helped us. But basically, what do we do? Always there is a blaming game. Doctors, nurses, the clinicians, they say the engineers are not doing things. We have broken equipments. And what do the engineers say? The engineers say, oh, the procurement are not buying spares. They say they are buying so and so and so. So we decided to make the visual management. You come and see what is happening. If it's the problem of the engineers, we know. If the problem with the procurement, we know. So visual management has been a key to bridge the gap between spare availability and the service to the clinicians. And the next has been the, thank you. Now from the systems, this is one of the Buganda Medical Center part which shows exactly all the data. You can see them, how they are used. You can see. And these are taken by the doctors, by the they own the process. They give the information, and you know that this is what is needed. And we started by having a few equipments, a few departments, which then we go on. First 3 departments, and up to now we are more than 12 departments, in which all the biomedical equipments are measured, controlled, and reported. So the management at Bugando Hospital has got informed decisions. This is how now our workshop looks. It's all glass. You can see from outside. No hiding place. You are working, you don't work, that's it. Sorry, I know the boss told me that I'm running short of time, but please come to Mwanza, BMC. And you can see the importance of biomedical engineering and how the openness, the transparency happens. Thank you. Please, Linda.
Thanks, Mr. Sajja. You can see the passion, I think, that he shows for health technology management. So I think just to finish off, quickly on sustainability. So obviously this is a central tenet to the program. And for us, that means co-designing, co-implementing, and co-investing. And the Bugando leadership, under the leadership of Professor Abel Makubi, but also now Dr. Fabian Masaga, they have really led and had vision for health technology management, and we thank them for that. And the results are clear. So over 5,500 work orders, increased from 900 from the first year we started tracking. And this year, its trajectory is close to 10,000 work orders this year. The uptime for operating theaters is increased from 60% to 90%. Those are critical surgeries that are now happening but couldn't happen before. With the same resources, with the same equipment, with the same people, we haven't changed the team. And the repair time is increased by 5 times. So what next? I think we want to continue building a community of practice for health technology management. People who are interested in this space, experts, the government, people who are interested in funding this. We want to replicate the Center of Excellence model. So we started at Bugando, but we can go to Dodoma, Mbeya, Iringa, Arusha, even Dar es Salaam. And we want those Center of Excellence to be vertically integrated with primary healthcare facilities so that they can also benefit from the healthcare technology management support. And with that, thank you so much for listening. Asanteni sana.
Thanks so much, Linda and Masanja, for a very informative presentation. Now I'm welcoming Earth Intelligence, Harrison Mariki. Harrison Mariki is a healthcare supply chain management consultant and co-founder of Earth Intelligence Limited, a community-based data consulting firm focused on supporting the public and private sector donors, philanthropy and governments in Africa, and leveraging data and emerging technologies to achieve goals of healthcare programs. Over the last 10 years, Harrison has worked mainly at the nexus between data use, supply chains, technology, immunization, HIV/AIDS, FP, human-centered design, and global development. Harrison has a degree in pharmacy from Rajiv Gandhi University of Health and Allied Sciences in India, data analysis skills through MTC and Harvard X, and is currently pursuing a master's in business administration. Mr. Harrison Mariki, you're welcome. You have 10 minutes.
Thank you so much. The mic? Right. Good afternoon, everyone. First of all, I'm very lucky to have been preceded by three powerful ladies, and also very strong organizations showcasing the good work that they are doing. Afya Intelligence is pretty new. We were established in 2021. I think when COVID hit, some of us found ourselves with enough time, and also when the pandemic really hit, we thought how best we could use the skills that we have to start and try and also help the stakeholders to address some of those challenges. So that's where we come from. We are pretty new, but I hope, and I think just today being here and being part of amongst these great stakeholders is a huge achievement for us. And so Afya Intelligence is a community-based firm. We focused in, so I think, all right. Yeah, so what we do is we mainly have three strategies. When you have big problems, then data is surely where to start off, and that's where we have started working on, making sure that we are creating the right insights that can support busy healthcare providers and healthcare managers, provide them with the right information so that they can act quickly. And so we also focus on making sure that the insights that we provide are also easily accessed. So also we deal with access. So we make sure that we integrate some of the existing systems with some of the widely used social platforms. So today you are excused to using your phone when I'm presenting, because we advocate for that, for people to use their WhatsApp and actually access information and make decisions. And we've managed to prove that is the case. So these are some of the challenges, or these are some of the setbacks that our healthcare workers or managers are facing. The path to getting the right insights is very long. Data is trapped in silo systems. And also, we always work with outdated information. Today is 12th, and probably the managers at subnational levels have not got to see what is happening at the facility. They'll come to get that maybe 20 days later, and by that time the facilities are already preparing new reports. And we have a very limited number of people who can really focus on data visualization. It's not easy, it's time consuming. We saw that with the COVID pandemic when it hit. The M&E teams at the Ministry of Health, even within the implementing partners, were really stressed because the data demand moved from quarterly to monthly to eventually on daily basis, people wanting an update on what's going on. And so we try to automate that process. And so our three current service offerings, and these are things that change every day because we're a startup, we can do that. But what we've figured out right now in terms of our experience for the past year is people need fit-for-purpose insights. They also want to access this whenever they can. And also they want to be able to predict what can happen next. Currently, our M&E, we are very much accustomed to looking at what has happened, and what we are trying to do is build a community with affinity and comfort to say this is what is going to happen. Start preparing, take action. So that's what we are focused on when we work with our teams. So when we started Afya Intelligence, we had like a big bold vision of saying crafting perfect healthcare experiences. So that's very bold. And somebody asked us, okay, so how are we going to measure that? It was a very difficult question, but we gave it a number and say, you know what, we'll figure it out, but we'll make sure that in the next year we are part of 25 million healthcare experiences when we figure it out. And so we took on the challenge of supporting and volunteering for the immunization program to do the daily data analytics and making sure that those are available for all decision makers, for all implementing partners who are getting funds and resources, so they could coordinate and change their strategies every day to make sure that they achieve the goal of vaccinated the eligible population, which is currently all adults above 18 years of old. So strangely, that number is very close to the 25 million. And so this was the case of one of the analytics that we did in March. You could see somewhere in the middle is pretty orange, yellowish, and a few regions towards green. And at that time, the scale we were measuring was around 3% to 25%. That's how the regions had done in terms of reaching their targets. 6 months later, this is the situation. 3 months later, that's in 3 months, you could see some of that middle, which was yellow, has turned to green. And also, like you could see, the scale has moved from 7% to now some of the regions reaching 44%. But this is, I'm sharing these snapshots on like quarterly basis, but this is information that was shared on daily and weekly basis to all implementing partners so that they could see where the issues are and act. So on weekly basis, people could get this access. And this is what has happened as of now. We have regions which have surpassed their targets, like Dodoma, which currently reads like 104%. This shows that the targets of the population in Dodoma is not what we thought it is, and hopefully the census that is coming, the results will really help us to see, okay, how many adults above 18 are really there in Dodoma. And we look forward to helping the programs to adapt to those new targets. We also keep sharing like what is remaining in terms of like and which regions we need to focus on to be able to achieve our goal of reaching the 100% of all adults by December 2012. So hopefully all these regions will change by the end of the month. So what are we saying? We are looking to support all the stakeholders in changing that affinity into looking into more predictive analytics, so moving from the traditional M&E into predictive analytics, supporting also like moving towards more, you look at the systems that we have, the DHIS2, the ELMISs, they have data of more than 5 years, which you could use. Yet, when we are doing ordering of commodities, we usually use like a 3 months average to inform us, while we have enough resources to help us to predict and really prepare or make the plans better. So this is the kind of service that we want to support, and also we want to make sure that we are able to engage quickly and provide feedback to the healthcare workers easily. So what we are saying is, what if it was possible for data to really be like a text away and people to be able to act? So like right now, one of the products that we are making is a chatbot that you could just interact with, and it will give you all the information that you need to act. That was supposed to be a video. It's not playing, but I'm sure you'll get to see it, and we have my friends there, Frank and Pasco, who can show you actually, and you can get to interact with the chatbot itself. Oh, it's actually playing. So this is just a case where someone is just sending a message prompted to use maybe a password to limit access, but immediately when you send that text, you will be prompted with the kind of information that you need. So that's a facility which needed out-of-stock notification to be able to proceed and purchase healthcare commodities from other vendors when they miss out information from MSD. So that process usually takes almost 40 days for someone to be able to get that document. But you could see with technology that could really be a moment. Once that is generated within the MSD systems, someone could easily access that on WhatsApp. You don't even have to have an application. So what we are saying is we are looking to this next year to push and get this in the hands of all healthcare workers. And we hope to be able to do this sustainably. We work with open source products that can easily be shared with our stakeholders and easily supported. We are building communities of like-minded people who are very much interested with data. I was especially encouraged with the previous presenters looking at the performance management and how that is used with the biomedical services. And I think we can do that also with our healthcare workers. Yeah, so we thank our partners who supported with us starting and looking forward to really do some more changes over the year. Thank you so much.
Thank you so much, Harrison Mariki. That was exactly 10 minutes. Another clap for him, please. I'm welcoming Fadhili Mtanga from HIMSO. Fadhili Mtanga is the Director and Chief Executive Officer at Health and Insurance Management Services Organization HIMSO, a Tanzania NGO based in Mbeya. He holds an MA in Community Development and Project Management from the University of Iringa, Tanzania. He has an extensive experience in project management in both local and international NGOs. He has managed projects in the areas of sexual reproductive health and rights, gender, youth empowerment, and livelihoods. He is also a renowned Tanzanian author and creative writer. Mr. Fadhili Mtanga, you're welcome.
Thank you. Good afternoon, ladies and gentlemen. And before I start, I'm sending you warm greetings from Mbeya and Songwe. And Mbeya and Songwe are the lands of waterfalls, beautiful mountains, good people, and everything that is good. I'm so happy to be here to make a presentation on how the Rafasta contributes to the access in quality healthcare services. So, no, you want to display for me?
It should display.
It is not again. I think I can use this one. Can you disconnect once half we answer?
In what office? In again. Your PowerPoint.
No.
Your PowerPoint. Open with PowerPoint 2016.
Okay, thank you.
Okay, cancel. PowerPoint.
I start by telling a little bit about our organization. Health and Insurance Management Services Organization is an NGO that was established and registered in Tanzania in 2012 to complement the efforts of Tanzania governments in providing comprehensive quality health care, as well as develop and implement innovative microinsurance solutions that address risk management needs of the low-income households. So since our establishment, we have been driving healthcare enhancement interventions while providing technical expertise for the development of social protection innovations. Currently, since 2016, we are implementing the Aurora Faster, which is an emergency transport services, while also co-managing Improve the Community Healthcare Fund in Mbeya and Songwe regions. The Aurora Faster has been designed after establishing that despite the efforts of the government, access to quality healthcare remains an issue for Tanzanian rural setting. Therefore, the Aurora Faster is a micro-insurance product that complements the attainment of health sector strategic plan number 5 from 2021 to 2026 by providing transport accessibility to low-income communities during medical emergencies. So through the Aurora Faster, through the Aurora Faster, individuals are transported from home to healthcare facilities and from a lower healthcare facilities to a high-level healthcare facilities when public ambulances are not available. Currently, we are implementing in 5 councils of Mbeya region, which are Mbeya, Songwe, Mbeya, Rungwe, Busokelo, Mbalali, and Chunya, and other 5 district councils of Songwe region, which are Songwe DC, Tunduma Town Council, Momba DC, Ileje DC, and Mbozi DC. The individuals in those regions and villages enroll themselves on annual basis upon payment of 1,000, the amount that is ranging from 1,000 to 2,500 per individual per year, depending on the geographical location of the district. Also, there is other village premiums where the villages are paying from 180,000 up to 220,000 per village per year. So the Aurora Faster, as I've said, is a microinsurance product which is a community-based approach toward improved social protection. Since it started in 2016 and it is managed as microinsurance product, designed the local solution to complement other health insurance schemes such as ISHF, and now we are poised to also support the UHI. CHWs, who are the community health workers, form the association from a village level or mtaa level to the district level. We provide technical and financial support for them to be registered in the community-based association at the district level, and the associations are known as Community Health Users Associations. The acronym is CHUA. So we as HIMSO, we collaborate with the CHUA and the local government authorities to co-manage the Aurora Faster and ISHF. The community engagement and empowerment through CHUA ensure the sustainability of this community-based intervention. Why do we implement the Aurora Faster? According to studies, people normally face 3 levels of delays in accessing quality health care. The first is the decision to seek health care. The second is timely transportation to the nearby healthcare facility, while the third one being receiving safe and respectful and effective health care at the facility. So one of the reasons why people do delay to make decisions to seek health care is because of the challenges on how are they going to be transported, and taking into consideration the complicated topographic nature of Mbeya and Songwe region and the other southern highland regions. So when people are assured of timely transportation to the nearby healthcare facility, it's very easy for them to make decision to seek healthcare services, especially for pregnant women and children. Therefore, after they have sought the decision and they have been transported timely, it's very easy for them to access quality healthcare services at the facility. So now I just want to show you a snapshot of how the Rafasta referral system works. We understand that our villages are of communal nature, so they know each other within the villages, and we use community health workers who are based at the specific village. So when an individual has experienced a medical emergency, the first thing, they place a call to the healthcare community healthcare, or face them physically. And when the community health worker has received the request, they reach the transport providers. We have contracted transport providers from each of the village that are in Mbeya and Songwe regions, because our area of intervention is the total number of the village that are in those regions. So when CHW have received the call, they place also the call to the nearby healthcare facility to ensure the availability of the service that is being sought by the particular patient. And in the situation that the nearby healthcare facility do not have the services that the patient is seeking, the CHW will place a call to the other nearby healthcare facility. Also, the CHW will also place a call to the contracted service provider, who might be the public ambulance, private ambulances, bajajis, bodabodas, and private vehicles. And in the situation that in the particular village the transport provider cannot be reached, the CHW will also place a call to the CHUA coordinator. In each district, we have CHUA coordinators who are managing day-to-day activities of the Dharura Faster, and the CHUA coordinator will place a call to the nearby village to find the available transport provider. And after the transport provider have been reached, will go to the home of the patients and transport the patients to the nearby healthcare facility. And in the situation, it's a referral from the lower level healthcare facility, the transport provider will transport the patient to the higher level healthcare facility. The other thing that I want to present is who are we working with in this the Faster scheme. First of all, are the community health workers who supported the execution at the village level, from the community sensitization, enrollment, receiving emergency calls, assessing the nature of emergency, arranging the transport, and inform the facility and provide the feedback. The other partners are the transport providers, who their significant role is transporting the clients to the health facilities and provide feedback. We also work closely with health care facilities which do attend the referred client and provide the outcome of the service. We also work closely with the regional and council healthcare management team, who they are overseeing the scheme, receive feedback, and enhance smooth implementation. We also work with the CHUA, as I've said, is registered at the CBO at the district level under the Community Development Department, who are responsible to manage day-to-day operations such as sensitization, premium collection, claim management, and communication and feedback. We are also having, we also have our financial partners who are UNICEF from Tanzania country office, and Bread for the World, that is the Protestant funding agents from Germany. Our achievement to date, so far we have already registered 21,950 individuals in Mbeya and Songwe. 2,000 have been transported to healthcare facilities. We have enrolled 200 villages. We have registered 10 churs and signed MOU with the 10 district councils and 2 regional authorities. We have identified and trained 856 community health workers. We have contracted 1,956 transport providers. We have trained the in charge from 431 healthcare facilities, and we are having 2 NGOs in Mbeya and Songwe who are supporting the destitute families. And among those people who we transport, the largest number is case related to pregnancy. So 84% of people who we have transported are pregnant women, and 12% are the children under 5. These are the pictures of some of our beneficiaries. Alicia from Lupepo village experienced 3 miscarriages before she was enrolled to the Rural Faster, whereby when she had a 4th pregnancy, she got twins. And we also have Rehema from Busokelo. She also experienced some challenges in the past, but after enrollment in the Rural Faster, she delivered safely. Do I have 1 minute? Enough? Okay, thank you. I just want to play this video, but it's a 1-minute video. Can you please allow me? Okay, thank you.
Kwa jina langu naitwa Elesia Anyitike. Mungu amenijalia nina watoto 2 mapacha. Nilipoolewa 2017, Mungu akanijalia nikapata ujauzito. Ujauzito ule ukaharibika. Nikapata ujauzito wa pili. Na hapo ukaharibika wakati umefika miezi 7. Nilipofika 2020, nikapata ujauzito mwingine. Naenda hospitali nikajifungua mtoto akafariki. Nilipofika 2021, Mungu akanijalia nikapata ujauzito mwingine. Kwa bima ya usafiri wakanisaidia kunipeleka hospitali ya hali yangu ya ujauzito niliyokuwa nayo haikuniruhusu kujifungulia hospitali yao. Wakaniambia niende hospitali ya uzazi NET. Napenda kuwashukuru watu waliotuletea hii bima ya usafiri na washauri wa kina mama wenzangu, jiunge na bima hii ya usafiri. Sasa hivi nimejiunga, Mungu amenifanikisha, nimefanikiwa.
Thank you so much. This marks the end of my presentation. Thank you, moderator, for an addition of the minutes.
Thank you so much, Fadhili, for a nice presentation. Now let me call Tasakta, Jackson Henrico. Jackson Henrico is a general practitioner working as a surgical and gastroenterology registrar and endoscopy assistant at Tasakta Hospital, Zanzibar. He is also a QI chairperson and TBQI secretary at the hospital. He earned his medical degree at Muhimbili University of Health and Allied Sciences. Title of his presentation is How Tasakta Hospital Has Revolutionized the Healthcare Industry with Minimal Invasive Surgeries. You're welcome, Jackson. You have 10 minutes.
Good afternoon. I'm Dr. Jackson from Tasakta Global Hospital, and today I will be talking on how Tasakta Hospital has revolutionized the Zanzibar healthcare system with minimal invasive surgeries. So I will take you through who are we, our fact checks, what we do, the minimal invasive surgeries in Tasakta Hospital, the bariatric surgeries that we are now doing, as well as where we are located. So first of all, we like to pay a tribute to a late Mr. Salim Turik, who is the founder of the hospital, as well as a group of company in Viga, Zanzibar, for his work that he made sure that the hospital stood in 2015 till to date. So who are we? Tasakta Hospital is a highly specialized hospital, a multidisciplinary hospital that is based in Zanzibar. We are located in Stone Town, just 5 minutes from the port, with a large team of specialized, competent, experienced, as well as professional doctors, with modern facilities, as well as, you can call it a state of art in technology. We aim at offering the finest and the best healthcare services to all domestic as well as international patients. So, what is TASACTA in numbers? So, we attend almost 400, 500 clients served daily. These are outpatients and inpatients with 130 bed capacity inpatients. We have the intensive care unit in place. We do minimum invasive surgeries as well as endoscopy studies with 7 dialysis beds as well as diagnostic, where we talk about digital X-ray, CT scan, mammograph, stress ECG, echocardiogram, endocorporeal, shockwave, lithoprost, as well as sonograph, as well as laboratory studies and more. So we have more than 12 specialties at the hospital with the emergency services that work 24/7 throughout the week. We have ambulances placed in different parts of Zanzibar. We know Zanzibar is huge, so for those people need these ambulance services, a dialysis unit with more than 20 specialists. We do laparoscopic procedures, we do endoscopy studies, also attend outpatients as well as inpatients. So these are some of our specialties ranging from hematology, anesthesia, as well as critical care, gastroenterology, cardiology, orthopedic, as well as physiotherapy, surgery, urology, endocrinology, nephrology, obstetric and gynecology, pediatric, dentistry, ophthalmology, and ENT, as well as dermatology. So at our hospital, we are accepting different types of insurance from our clients, from the National Health Insurance Fund, as well as other insurance such as Strategies, Assemble, Jubilee, and Britam, and more, as well as local insurances in place. But we also accept international insurances for tourists, such as Resolution, Atna, Cigna, and more. So, the talk of today, how TASACTA Hospital is advancing the healthcare industry with minimal invasive surgeries. So, we can say that we are pioneers in Zanzibar Island because we are the only facility currently doing laparoscopic or minimum invasive when it comes to gastroenterology. So what are the minimum invasive surgeries? We say, in contrast to the classical or traditional surgeries, minimum invasive surgeries, these involve techniques that limit the size, the size as well as the number of cuts or incision, where special equipments or small equipments are placed through the ports that are made, and with help of this, we are able to do diagnostic, we are able to treat, and to do furthermore. So, with minimal invasive surgeries, we say small cuts makes a big difference. So, what are the advantages of minimal invasive surgeries? Less pain for those who undergo this, say less bleeding. They have less hospital stay. Means these people who undergo this, they may stay in the hospital 3 up to 4 days. Some may even go on the same day, and some of this procedure may be even done as an outpatient. Also, cosmetic scars, contrary to the traditional or the open surgeries with minimal invasive surgeries, there's a limit or size of the scar, so it's essentially cosmetic, as well as increasing safety, and they are less costly, or we can say they are cost effective. So what is the milestone of minimal invasive surgery in Zanzibar? Prior to 2013, there was no any minimal invasive locally in Zanzibar, but after 2023, the government of Zanzibar, with the collaboration of Chinese government, periodically they started bringing doctors for endoscopy studies only, and as well as laparoscopic, with time to time where they would have gone back. So in 2017 is where a medical gastroenterologist joined the Mnazi Mmoja National Hospital. So, and it was limited to endoscopy studies, means upper endoscopy as well as lower endoscopies. In Tasakta Hospital 2020, we had a first gastroenterologist joined the team. Is when we started full implementation of the minimal invasive surgery. So about the hospital itself, what we did and what we achieved, and also we published this, we were able to do a laparoscopic cholecystectomy to a pregnant woman, 20 weeks of gestation age, who had acute calcareous cholecystitis. So this is one of the biggest achievements that we were able to operate, as well as we understand the implication of this disease in pregnant women. So, in terms of statistics, we do 20 endoscopy on average every week. This including both upper and the lower endoscopy, means OGD as well as colonoscopies, where we have 2 days, Tuesday as well as Fridays, for these studies. So in terms of laparoscopic, what we have achieved for the all patients that we have operated on or who undergone minimum invasive surgeries, more than 37% of these patients underwent cystectomy. This due to ovarian cysts, it could be due to renal cyst as well as hepatic cyst, but a large number also was appendectomy, laparoscopic appendectomy due to appendicitis. 28% underwent cholecystectomy, 24% laparoscopic, as well as splenectomy. For most cases, we had almost 1.6 for sickle cell patients who underwent splenemia, and 7.9% of these were diagnostic laparoscopic, means we are trying to find what's wrong to these patients. So in terms of minimal invasive surgeries, what we do, mainly we do laparoscopic appendectomy for appendicitis, we do laparoscopic cholecystectomies for disease related to the gallbladder, cholecystitis, cholelithiasis, also splenectomy. We also deal with ovarian as well as renal cysts, including hepatic cyst, inguinal hernias. Currently, we are doing laparoscopically, as well as we do diagnostic laparoscopic, as well as adenomyosis. So this is one of the image, together with our gastroenterologist, Dr. Alexander, and I, performing a laparoscopic cholecystectomy in our facility. So also another thing that I'd like to talk about you that we are doing at our hospital, this bariatric procedure. What are the bariatric procedure? These are non-invasive procedures that IMD for people to reduce weight. For those who traditional means have failed, means diet has failed, exercise has failed. We know that obesity is the risk factor for major disease, heart disease, diabetes, hypertension, stroke, kidney disease. So for people who are obese and really want to reach these targets, we have introduced what we call the intragastric balloon that we do. We are the only one doing it in Zanzibar. So how does it work? So this is the temporary non-invasive surgical weight loss procedure, which involves insertion of a special balloon. Okay, one more minute. What it does is that the balloon, once placed in the stomach, it reduces the volume of the stomach and make this person eat less. In such a way, it takes a period of 6 months to attain almost 10 to 15 to 20% of the current body weight loss that is placed. What you see on the image is one of the balloons that we have placed. So far, we have a success rate of 100% with no complaint or any patient who has came for revision of this. So these are our contacts and where we are located in Zanzibar. You are all welcome in Zanzibar. Thank you.
Thank you so much, Jackson and Enrico, for a nice presentation. Now I'm welcoming George Ruhado from Umati. He's going to present on the health system cost of post-abortion care in Tanzania. Dr. George Ruhado is the health economist and senior lecturer at the School of Public Health and the Social Sciences of the Muhimbili University, Tanzania. He has received his PhD in health economics from Belgian University, Norway in 2015. Ruhado research is focused on cost effectiveness, equity analysis, and priority setting of health interventions in low-income countries. Ruhado is a member of the Global Burden of Disease study of the Institute of Health Metric and Evolution at Washington University. He has done a number of consultancies of health financing, costing and cost effectiveness of health programs for international organizations such as USAID Global Fund, UNICEF, Save the Children Fund, Swiss Tropical and Public Health Institute, Lexi Consultant USA, and Deloitte Consulting among the few. You are welcome, Dr. George Ruhado. The floor is yours.
Thank you very much. It's a little bit complicated presenting at this time of the day when everybody is probably looking for a late lunch, but I'll try my level best. As rightly said, what happened? Is my power go off? I'm sorry.
We will still have two presentations to go, one from FarmLinks and the other one from NMB. So let us be patient, please. After that, we'll break for lunch.
Seems even my computer is hungry. Okay, thank you. So as you would see, this study was done between Muhimbili University and the Guttmacher Institute, but also it was supposed to be disseminated by Umati, which is chama cha malezi na cha uzazi na malezi bora Tanzania, established in 1959, and we collaborated so that based on the experience in sexual and reproductive health, to disseminate this study result. And is the key issue here, we are trying to inform decision makers, but also the implementing partners to be able to address the challenge. Basically, as we all know, abortion is legally restricted in Tanzania, and is interpreted in the Penal Code to allow abortion only to save or preserve the mental and physical health of women, but access to safe abortion services, even for legally authorized persons, is still limited. Back in 2023, we conducted a study in Tanzania on the incidence of abortion, and it was around 36 women in every 1,000 women, or around 67 women were being treated in health facility for post-abortion care. And the health system cost to manage this complication will definitely be significant, and these costs are largely avoidable, and we believe can be freed up to provide services elsewhere in the health system. And we know that the government of Tanzania is committed to improving access to life-saving post-abortion care services to reduce maternal mortality. So the aim of this study was to estimate the post-abortion care in Tanzania health system. This was done in 2018 at the service provision level, and to look if access were expanded to meet all need for post-abortion care. We estimated the fee charged to post-abortion care patients, but also compared costs to associated with expanding the contraceptive services. So we used the post-abortion care costing methodology that was developed back in 2018. It has been used in sub-Saharan Africa, in Ethiopia, Uganda, Rwanda, Senegal, and currently we are providing capacity to Gambia and also I think Kenya to do similar studies on this. So we use a method that's a bottom-up approach or ingredient-based approach where we collect data from the base down level. And this was based on key informants at the facility level that gave us the ability to yield the exact values. We started with the universal facilities of offering post-abortion care in 2017. It was around 1,187 and around 388 in Zanzibar. We excluded 450 facilities that had less than 5 patients a year. Also 8 maternity homes, military hospitals, and 1 facility was closed. So we remained with 757 facilities. For the range of geographical location, ownership, and facility type, we remain with 40 public and private facilities, but also depends on the availability of resources to be able to do that. Interviewers used 2 questionnaires to collect data, which were key informants at facility administrator levels. So this is the type of data that we collected. That was direct costs, included clinical personnel such as clinical staff salaries, time spent per patient, but also other supply that are used such as consumables, more equipment, medication, and laboratory and diagnostic tests that are used to provide the services. But also there's indirect costs such as buildings, capital costs that are used to construct and equip facilities, the overhead costs such as maintenance of building, utilities, electricity, travel, audiovisual, information, education materials. But also there is indirect personnel. There are numbers that are non-clinical staff, but they're also providing services in the facilities. And we collected fees that are paid to access these services, just in case they do it. So we did the data analysis by estimating average cost per patient, using the sum of the average indirect and direct costs, and then we extrapolated average cost per patient by facility type to national level using the data that we had collected, and then we inflated that to the value of 2018 by that time. So this is our results. We had a national hospital, regional hospital, district hospital, a health center, that's a PHCU plus in Zanzibar, or a dispensary, that's a PHCU in Zanzibar. And we had ownership that was public and private facilities, where 7 were public and private were 12%. As you could see, in these regional hospitals had the highest number of post-abortion care case load, where there are around 553 cases in that, and the highest percentage were in complete abortion, followed by sepsis, shock, and perforation. So these were different types. In total, around 77,814 women received post-abortion care in Tanzania, and a majority of them were at public facilities. But as you would have seen previously, the largest number were around 67,004 in complete abortion. And the average cost to provide post-abortion care was around $58 by that time. And the cost nationally was around 10.4 billion, meeting only for post-abortion care. We raised this cost to around 25.7 billion. And this is a large amount of money being spent there. And incomplete abortion and sepsis were the most costly complications, as you could see there. So on average, the total cost per patient that sampled facilities were lower at private facilities than public facilities. And we know that post-abortion care services are supposed to be provided for free, but it seems an average charge per patient was around $14,000 at facilities. And women, overall patients were charged a fee and supply cost equivalent to around 82 million Tanzanian shillings. So what are the implications of the finding that we found? One, what we can take away is that around 77,814 women in Tanzania receive post-abortion care, but an additional 114,000 women may need this care, but they're not receiving that. And post-abortion care costs the health system around 10.4 billion Tanzanian shillings per year, and this is avoidable costs. We know that it could be prevented. Meeting the needs of post-abortion care in Tanzania could drive this cost to around $100 million or 25 billion, and facilities only recover around 100%. The health system cost of operating, as we said, is significant. Increasing access to contraception that could reduce unintended pregnancy, and we believe that could reduce the needs for post-abortion care and generate cost saving. And the family planning data in Tanzania by that 2 years ago found out that only 33% of women were receiving modern contraception, and only 23.3% of married women have unmet need for modern contraception. So the annual cost for providing modern contraception in middle income countries is around $1.9 per person. And for each $1 invested in contraception services beyond the current level, the cost of pregnancy-related newborn, including PAD, will increase by 3%. So we believe by increasing the budget for family planning, we will reduce significantly unnecessary costs for post-abortion care, which is unsafe in most cases. And only around 10% of women had insurance, which is probably a problem, and that need to be looked at. And we know that the commitment to sexual and reproductive health is going down in a way. So what do we need to consider is that it's important that patient costs are managed and as insurance scheme cover to reproductive waste, and probably we're going to universal health coverage that could be taken care of. But the key issue here is that we need to consider providing family planning services, as the cost of post-abortion care is very, very, very high. And as in economics, we say there is no free lunch. For every resources that you spend on post-abortion care could have been spent for something else. So it's always having another thing to do. So if a woman spend that money to go to a hospital for post-abortion care, could have spent the same resources on something that's important, educating the kids and doing other important things and saving for improving their livelihood. Thank you very much. That's all.
Thank you so much, Dr. George, for a nice presentation. Now I'm welcoming John Method, titled Pharmaceutical Supply Chain Improvement Using Digital Technology, a case of Farmlinks, Tanzania. John Method is a junior pharmacist with a bachelor degree in pharmacy from Muhimbili University of Health and Allied Sciences, MUHAS. He is passionate about digital health technology, innovation and creative graphics designs. He has co-founded and worked with 2 successful digital health innovative startups that aim at improving the health of the community. Currently, Mr. Method is the operations manager at Farmlinks, a digital innovative company which is transforming the supply chain of pharmaceutical products in Tanzania. John Method, you're welcome. The floor is yours.
Good afternoon, everyone. My name is John Method. I'm a pharmacist by profession and also work at the Pharmacy Council, the body that regulates the pharmacy practice in our country. And also, I'm an operations manager at Farmlinks, a digital innovative platform that aims at revolutionizing the supply chain of pharmaceuticals in Tanzania. So today, I will speak on what is Farmlinks, what we are doing in the health sector, especially in the pharmaceutical supply chain, because the pharmaceutical supply chain is a little different from the supply chain of other normal goods. And So yeah, a little bit about the pharmaceutical supply chain. Before I start, I'd like to share a simple but provocative question. How quickly would you make a decision if you had all organization data integrated and analyzed in real time? The main aim of this question is for you to think on how important data is in organizations, especially in the health sector. And I would like you to think on how you can use the benefit of data in improving the quality of services that we provide in our health services. So, a supply chain is a network of activities, shareholders, and people who are involved in the manufacturing of pharmaceutical products, from the manufacturers all the way down to the patients who are consuming these medicines. And from this definition, one thing is very clear, that the pharmaceutical supply chain is a very complex one. And there are 2 reasons for this complexity in pharmaceutical supply chain. First is the high number of stakeholders that are involved in the supply chain of pharmaceuticals. There are manufacturers who are usually located in different countries, mostly in Europe and Asia. Also, there are importers who are then allowed to import only a certain amount of drugs into our countries. Also, there are wholesalers who are collecting everything and supply them to the retailers. Retail pharmacies, and also to the private facilities, dispensaries, and private laboratories. This complexity calls for very stable and a very efficient supply chain in pharmaceuticals in order to make sure that the community gets, the medicines are available and accessible at affordable prices. The other reason is that we know that pharmaceuticals are special kind of goods. They need they need special handling when moving from these different entities in order to make sure that the quality is not compromised and to make sure that the people who need medicines get the medicines in right time and in right quality. So, as I described earlier, all this complexity in pharmaceutical chain, pharmaceutical supply chain, lead to a lot of challenges in the market. The first one is large inventory. Always there's a constant increase in the generic medications and the brands that are registered and being sold in our market. So it is becoming very difficult to keep track of these new medicines and information, and it's even harder to retrieve them when the information is required. Also, there's the demand variability in the market. We know that there's a difference between what we expect to happen in the market and what actually happens in the market. So diseases, they change. Some new diseases come in the community. Some of them erupt. So it is very important to have data that can predict and give us information on what is going to happen, let's say in 5 years or 10 years before it actually happens. Also, because of the nature of our market, it is operating in a very manual, and most of the documents are in hard copy. We have a lot of data which is not yet analyzed. And a data which is not analyzed is meaningless, because the goal is to change data into information and information into insight. So if you have a data but it's not analyzed, it's a burden which is not useful in the market. Also, because of all this and unnecessary activities that are happening during different steps in the supply chain, together with lack of transparency in the supply chain, the patients themselves face a challenge of high prices of medications, because maybe they don't know who has the best medicines and good medicines at affordable prices. So, because of these challenges that are facing the pharmaceutical supply chain, we came up with FarmLinks. FarmLinks is a digital, innovative health platform that seeks to improve the health of Tanzanian community by ensuring the supply of quality medications from the suppliers to the retailers. So, in this complicated pharmaceutical supply chain, we chose to link and facilitate the movement of medicines from the suppliers to the retailers. And this is us, FarmLinks. We are linking the suppliers of pharmaceutical products and the retailers or health facilities, private dispensaries, and so forth. So, this is our partners, COSTECH, the Commission for Science and Technology in our country. Last year, they had a challenge called the Tuge Challenge, in which they support us with trainings and mentorship, and also they support us with funding to develop different products that we already have in the market. The first product that we have in the market right now is FarmLinks as a service platform, which is a digital platform that enables suppliers of pharmaceutical products to showcase what they have in their stocks online. So instead of a retailer of pharmaceutical products to move around from the premises to the city center looking for medications, first is moving from the premises to the supplier, and also it is moving from one supplier to another, looking for the best prices, and also it is also difficult to get everything you need from one supplier. So it's always moving around, collecting everything from different suppliers to make sure that you have everything you need. So with FarmLinks, we have an Android application and a web-based application in which we recruit these suppliers, and they open virtual shops in our platforms, and then these virtual shops can be accessed by retail pharmacy owners, and by using their mobile phones, they can actually log into their account and see what supplier has which products at what prices, and themselves can compare which suppliers has the best medicines and which suppliers has the best prices, and actually make an order, and that order will be delivered to their doorsteps very quickly and in real time. You can see one of the interface of our application. It shows the picture of the products, the brand name, and other information pertaining that particular drug. Also, we have the FarmLinks customized platforms. This happened when we were moving around, recruiting the wholesale pharmacy owners, because some of them were having challenges already in keeping inventories of their products. So they give comments and opinions that we make customized platforms for their businesses. And this is one of those platforms in which he is having 250 clients who are making orders through the platform, and up to now, in September, he already had made more than 5,000 orders via the platform. I'd like to end my presentation with this quick survey that we did in partnership with Apotheca. We did a survey in Dar es Salaam, pharmacy owners, and the results were interesting. 73% of pharmacies, they reported to have facing challenges by the current method of procurement of medications. And 54% of them, they had an idea of an online commerce. They know what is online platform that you can make an order via an Android application in your phone, and you can actually have those goods delivered to you in real time. Also, 74% of those pharmacies, they had internet connection. Internet connection is a very important factor in working with the online platforms. So if 74% are having internet connection, it's actually very, very easy to work with online platforms. Also, 90% of pharmacies were ready to use online platforms to make orders of the medications, such as FarmLinks. This is very good insights, and this is what keeps us moving to make sure that we reach a larger percent of these pharmacy owners and ease the burden to the final consumer. Thank you very much. We have a booth out there. It's called FarmLinks and Acostec. If you want to reach to have more information, you're very welcome, and this is how you can reach us. Thank you very much.
Thanks so much, John Method, for that presentation. Now I'm welcoming NMB. The presenter is Zakaria Steven, is the product manager at Digital Global Transactions Services for NMB. Zakaria Steven is an experienced banker working with NMB Bank as a product manager at Digital Global Transaction Services and a transaction banking department based at the head office. Before joining NMB, he worked with Citibank Tanzania Limited as an analyst and at the Treasury and Trade Solutions Department. He has 10 years plus of work experience in the banking industry. Mr. Zakaria Steven, you're welcome. The floor is yours. You have 10 minutes.
Thank you. So let me make it very short since we head into our lunch, right? Okay, and with that reason, I will skip some of these slides, which I think they will take as much time to go through. So I'll skip the introduction part, and I'll go directly to the banking requirement overview. So the introduction part was simply telling us like what is NMB in terms of history, where we started and where we are, in terms of our performance and how we have been transforming from, in terms of ownership. So let me directly go to the banking requirement. I've actually gotten an opportunity to listen to some of the presentations, and I could clearly see that there is one leg which is missing, and this is actually the banking sector as part of the entire ecosystem of the health sector. Like the previous presenter, FarmLink, I could see that they have come up with a good idea in terms of putting together all the information needed by the health sector, but when it comes to payment, this leg is missing. And this is what I'm actually going to focus on in terms of the collection and payment solutions. These are offered by the bank, basically. So, as you're aware that we are now focusing on digitizing our operations as a bank, and with this one, we want to make sure that we accommodate our customers or our clients in terms of giving them with digital solutions that will help them to perform their daily activities when it comes to collecting funds from their customers, and also to make some payments to multiple beneficiaries. I understand that health sectors are involved in collecting funds from their customers when they get services, and also they have to make some payments, the like of salary payments and so forth. So in terms of digital banking, the bank is having integrated solutions that can be integrated to different platforms to make sure that everything is automated in terms of collecting the funds from customers. And our customers are now looking for convenience, not only in the banking sector, also in the health sector. Customers would prefer more convenient ways of getting services from your healthy facilities. Now, in terms of payments also, how are we prepared as banks? So we are also having multiple payment options, which are obviously convenient to our customers. Like they can make payment anywhere. They don't need to walk to the banking halls, etc. And also in terms of reconciliation, because most of the businesses, particularly in the finance department, would face challenges to recognize like this payment is coming from who. Now, our solutions, our collection solutions, are structured in a way that they provide the key information that are useful when it comes to reconciliation. I'll talk a bit more in the coming slides. Also, in terms of sales support, like now you've been given a solution by the bank, now you come to ask yourself, so what do I do in case I want to ask you, like, if I'm stuck in doing some transactions, what do I do? So we also prepared in terms of having a dedicated team that will support you for the service that you have received from the bank. Now, a bit more on our offerings. So I've actually selected few solutions catering for the services that health sectors are getting and offering to their customers. So at the bank, we have collection solutions. Now, when I talk of collection solutions, what do I mean? So you have your customers who are coming to your hospitals, for instance, if you are a health facility, you're offering services. Now, they want to make payments. So you have all the, say, billing systems, in case you have billing systems, or you're working with partners who are providing software for you to generate some bills. Now, what do you do when it comes to payment? This is where you need a bank. You do system integration with the bank, so much so that when it comes to payment, once you have generated a certain control number or reference number, you give your customer, you ask them to pay through the bank. And now, at the bank, we have multiple options that the customer would use to make payments. We have liquidity management options. Now, this is to do with investment. If you have idle funds that you would want to earn interest amount out of that, you could actually reach us and then make investment. So we have cash in transit and implant services. Now, for those who are collecting a large amount of fund over the counter. So there is this option where we can put our cashier and then they can collect on your behalf. So you make your staff get rid of, dealing with cash. So as a bank, we also facilitate that. And then we have trade finance offerings where you can approach us for letter of credits, invoice discounting, guarantees, documentary correction, etc., etc. Okay, so a bit more on the payment solution, and this is basically internet banking. So with NMB, you can actually get to access our internet banking portal and make a number of payments that you would want to make. Not only payments like salaries, you can also do some government-related payments that requires you to pay against control numbers. Now, let me talk a bit more in details on the digital collection solutions. I said that we have multiple payment options, and what did I mean in this? So look at the diagrammatic representation of the digital collection solutions. So on the left-hand side, you see those are the available multiple payment options. So once you give your customer a reference number, like you go and make payment into my account using this reference number. So they get to use any of the available payment options. And then once the payments are made, on real time, the amount will be reflected into your bank account sitting with us. And again, it will update you in your platform or portal that generated that reference number. So the whole purpose of integrating systems like the banking system and the health facilities system is just to make sure that payments are reflected into your account on real time, and at the same time, the bill is knocked off in your billing system on real time. Hence, it makes your reconciliation easy, that you can simply pull a report and then see all payments which have been made and all payments which are yet to be made. Okay, so all our value propositions, we have tailor-made solutions. What we do at NMB, you just come up with your idea, you tell us what you want from us, and then we design a tailor-made solution based on your requirement. So we have both on-shelf solutions and tailor-made solutions. So we are that much flexible to make sure that we accommodate all of our customers' requirements. And this is achieved by investing much in technology. We have dedicated technical support team that are there to support you in case of any challenges. We have multiple payment options, as I said earlier. And of course, we have a dedicated relationship team that is available to support your banking needs. And we ensure we capture key transaction information that will be useful for you when you are making reconciliation. And of course, our ability to make transactions 24 hours in a day. So this is, in short, about what we can offer at NMB, but if you want to get these services, you simply need to walk into your nearest NMB branch, where you just say or mention your requirement, and then we will be contacted, and then we will assist you. Thank you so much for your time, and bye.
Thank you so much for your presentation. A round of applause for him, please. All right, that's fine. So we are breaking for 20 minutes. For those who haven't taken their lunch, kindly go to Mkomazi Hall with the same coupon. You take your lunch, then you'll come back for another forum. We have a forum in gender health. So according to the audience, we'll see. Kindly go take your lunch first, then come back, if you haven't taken your lunch yet. Thank you. Because at 18 hours, you have to be at the main hall. There is cheer awards and healthcare awards. So it's good to be at the main hall at that time. So let's try to keep time.
Hello. Karibuni sana. Tunaendelea kusubiria participants waweze kutujoin kwa sababu lunch kwa kidogo imekuwa extended. So as soon as we get a bit more of audience, tutaanza. Hello, karibuni sana. Session yetu itaanza saa 9:30 on the dot. Please bear with us. Tutaanza saa 9:30. Hello, good afternoon everyone. Welcome to this symposium where we're talking about social inclusion for young people and people with disabilities in sexual reproductive health. I would like to start introducing our panelists who will come up, and then we'll give a brief overview of this session, and then we'll welcome your questions after the panel have presented some of their topic. And this again, we will not have a formal presentation, but we'll have a dialogue on the topic. So to start, I would like to welcome our first panelist, Dr. Moke Magoma. Dr. Moke is the country representative for Engender Health Tanzania. He has over 25 years of experience on public health and clinical care. His areas of interest include health management and service delivery, RMCAH, programming and service delivery. Dr. Moke holds a medical degree from University of Dar es Salaam, MD in obstetric and gynecology from Makerere University, and a PhD in epidemiology and population health from University of London. Dr. Moke, karibu sana. Our second panelist is Fatma Yahaya. Fatma works with the Ministry of Health Zanzibar in integrated RSH program as Information, Education and Communication Behavior Change Officer, where she leads the adolescent and youth friendly intervention. She has a vast experience on health promotion and health education on SRH, including family planning, for over 6 years. She's also a national trainer for youth-friendly and inclusive services for all people, including people with disability. Karibu sana, Fatma. Our third panelist is Subisia Kabuja. Ms. Subisia is a senior social welfare officer at PROLG with expertise on child protection, gender-based violence, National Integrated Case Management System, psychosocial care and support. She's a national coordinator of child protection, including for children with disabilities. She holds Master of Science in Development Policy and Practice for Civil Society at Bradford University, London, Advanced Diploma in Social Work and Institute of Social Work, where she got that at the Institute of Social Work, and a Diploma in Education at Morogoro Teachers College. Karibu sana. Our fourth panelist is Otuk William. Otuk has spent the past 10 years building and fostering youth-led SRH movements, mobilizing resources and advocating for AYSRH at national and international stages. He has made an impact by bringing young people on various SRH decision-making platforms as equal partners. Through his leadership as Managing Director for Young and Alive and a co-chairperson for the Tanzania Adolescent and Youth Health Network Coalition. Otuk is also a musician. Otuk, karibu sana. Thank you. Yes, our fifth panelist is Dr. Isa Suleiman. Dr. Isa is the head of Department of Obstetric and Gynecology at CCBRT. He served as a maternal and newborn project manager in Unguja previously, with a focus on reducing maternal and newborn morbidity and mortality. He is pioneering better services to pregnant adolescent and pregnant women with disabilities. He has researched on female genital mutilation and adverse birth outcome in Tanzania in 2020. Dr. Isa, karibu. So, along with the panelists, we have your moderators. I'm Dr. Anna Temba, Technical Director for Engender Health, and I'm co-moderating with Frederick. Karibu.
mic was not working. I'm Frederick Msigara. I'm from CCBRT. But we are working together with the Gender Health, implementing a program called Scale Up Family Planning Program as technical advisor on disability inclusion. You are welcome.
Frederick. So our topic today is inclusive SRH services for young people and people with disability. And we'd like to learn from the panelists and from you all what works for Tanzania. Because we know different programs have been implemented in different places, but what are the lessons from the ground? And why these two populations? So starting with the young people, we have an average of 12 million adolescents in Tanzania. This is a huge number. And this huge number poses a huge potential for development, both health-wise and economic. But we also know and are all aware that young people face various barriers, both from the supply side and the demand side. So they also have their own barriers based on their culture, their religious environment that is available, that hinders them from, and even knowledge, that hinders them from actually wanting to access the service. But even the few that wish to access service face different barriers at health facilities, and some of the policies are also not friendly, or they're not talking to each other that will support this adolescent and young people to access services. I'll push now to my co-moderator and talk about why we have to include people with disability. Karibu, Frederick.
Thank you, Anna. When it comes to people with disability, according to the National Bureau of Statistics, around 9.3% of the Tanzanians are people with disabilities. And many of them, when it comes to accessing healthcare services, they are facing a number of barriers that limits them to access the healthcare services in various facilities. These are related to the attitude of the service providers, could be environmental infrastructure, it could be even the equipment that we use to provide services to people with disabilities. According to the World Bank and WHO report on disability of 2011, 15 up to 20% of the world population, of the poorest people in the world, they are the people with disabilities. So there is a very close relationship of disability and poverty. And because of that, then any intervention that we are making, we have to ensure that we include people with disabilities. According to Sustainable Development Goals, we have this motto that leave no one behind. As healthcare actors, we need to ensure that we include the people with disability. Tanzania has a number of laws, international and local laws, that protect and promote the rights of people with disability. You have the Constitution of the United Republic of Tanzania, which prohibits all discrimination against people with disability. We have the Convention on the Right of People with Disabilities, which also promote the right of people with disability to access family planning and sexual reproductive health services. So, despite of the intervention that have been undertaken, people with disabilities are still accessing some services as they would like to access as per the laws and the various international instruments that were signed. So from this discussion today, we are going to see what are the challenges and what are the good initiatives that have been taken to address the challenges, and what we need to do more to address, issues of disability inclusion in service provision. Karibuni.
Asante sana. So starting with the panel, inabidi tuanze na the young and their life. The young people. And for us, again, to be inclusive, we also want to use both English and Swahili, because we also have our beneficiaries in the house, and we'd like also them to understand what we are talking about today. So, William, as you are responding, please try to mix both languages. So, William, what are some of the challenges that young people face to access use and continue using. Because I think once they use, we also need to retain them to services as users, but also as ambassadors of services. So what are some of those barriers? And again, on the other hand, we're also talking about engagement of young people. But again, in practice, it does not really happen as we would desire to happen. So again, what are some of the barriers that make young people not to engage as they should? Karibu.
Thank you, Anna. Good afternoon, everyone. I believe it's an afternoon. Habari za mchana. As Anna said, I will try my best to use both languages when I can. So if imetokea kwamba natumia lugha moja zaidi ya nyingine, utakuwa unanikumbusha. So what are the barriers? I think most of the barriers are very obvious, and we will talk about them here and break them down a little bit. But I'm a person who also wants to also talk more about what do we do about those barriers. So I'll try and capture both aspects. So we both know that majority of adolescents and young people are still living below the poverty line. Young people are still poor in most of the places in our country. And even though some of the sexual and reproductive health services are provided, quote unquote, for free in public health care facilities, still there's a lot of costing that goes into how these adolescents and young people are accessing the services. So for example, how does one come from the entire village or households to a health facility that is located 10 kilometers away from where she or he is. Kwa hiyo umbali tu wa kutoka sehemu moja kuna nyingine ambao unaweza kaita accessibility, but still there's a cost implication to that. Is a big barrier considering the fact that adolescents and young people, most of them don't even have jobs, don't even have stable income, and the services could be costly. But also some, and maybe majority of adolescent and young people do not even know that these services are available and they are available for them. So they might think that family planning is for, quote unquote, married couple or married or adults per se. But we both know that based on our guidelines, these services are accessible to even adolescents and young people. But also availability. So we know that this is a problem in our country, that in a lot of our facilities, especially at the primary level, availability of these services is also a challenge, whether we're talking about commodity stockouts, whether we're talking about lack of healthcare providers who are trained to attend young people. All of these contribute to the availability of services. But I would want to insist in one thing, which is stigma. I'm going to use that word, makusudi kabisa. So we're always talking about provider bias, which is one of the barriers to youth-friendly services. And when you unpack provider bias, you find that it's actually built upon the general, I would say, understanding or the value of our society or community towards, the attitude of our community towards young people when it comes to issues of sexual and reproductive health. I would say a lot of adults, a lot of us, are not comfortable with the fact that young people and adolescents are having sex, but they do. And we have to face that reality. Even though we might have our own values, our own perception, our own ideas, but still these things are happening. So as programmers, as people who are trying to reach out to adolescents, as people who are trying to expand access, we need to look at how can we now look at the households and see what are the kind of resources, even non-material resources that they have that could, improve health. We know that health is produced at a household level. And so if the parents are well aware of the services and the importance of services and information that young people need to have, they are more likely to expose their children to to care and services. And those children, when they grow up, they are more likely to expose their children to care and services. So you create jamii ambayo ina utamaduni wa ku-access services moving forward. Lakini when the household change, you will see that ripple effect kwenye community. Now the community will start to change. You will start seeing people being more positive kwenye masuala ya huduma. But when we're talking about community, we are not only talking about people like our beneficiaries, we are also talking about ourselves, because we are also communities. We create this, we are working in these organizations that we're supposed to create programs that should reach young people. And as organizations, as people, as professionals, as elite, we have our own understanding, our own values, our own culture. And sometimes those don't match or don't align with the needs of young people. And that is why we're always talking about engaging young people. But then the question is, how does that look like, right? Because it's one thing to have a young person on the table, but it's another thing to listen to what that young person is talking about. Anna, you asked a question about how do we make sure that young people are comfortable coming on the table, contributing, na kusema kile ambacho wanajisikia. I think that's a challenge that most of adults have. Mimi naweza tu nikauliza hapa kwa haraka haraka, how many of you are on TikTok? Only one person, right? Wangapi tuko TikTok? Some of us don't even know what it is, right? So that is a disconnect that we are having. And I'm saying this because even myself, I had to challenge myself on that level. I mean, I'm on social media, but TikTok wasn't a platform that I like. Lakini, the majority of adolescents right now as we speak are on these platforms. And the content in these platforms, if you go there, then you realize that we need to change our approach. We need to look into the programs that we are designing and see how can we reach the generation that is on TikTok right now. And there's a video of a person who is talking about how to have safe sex, and it's not actual information. So we need to look inside. We need to do introspection and see what is the new generation talking about. What are they doing? So that we can align that with our programming. I think that could help. Thank you.
Thank you very much. A round of applause, please, to our... Asante sana. So, William bring a good point that I would like to, insist or, just reflect on. Ya kwanza, availability is not equal to accessibility. Kwamba tunaweza tukasema huduma zipo, lakini je, ambao tumewaandalia wanajua huduma zipo na ziko halali kwao? Lakini tukisema pia zipo na zipo bure, je, tumeangalia wanafikaje kwenye kuzifikia zile huduma za bure? Lakini na sisi ambao tuko nao, je, tuna connection gani between us and them? Now that applies to everyone, the programmers, the parent, the service providers. Je, where is the gap? Do we know the gap, and how are we connecting the dots? But I think another thing ambacho amesema, kuna big stigma. Na hiyo stigma pia inapelekea sana kwenye kufanyaje kutokupata huduma. Na stigma nyingine tunajidanganya kwamba hatutaki waende kituoni kupata uzazi wa mpango kama vile hatutaki wafanye sex. Lakini in reality this is happening, we need to face it. And he posed a point kwamba we need to build that culture ya vijana kwenda kupokea huduma. Tuone kwamba it's normal. Na tunapata kuibuild kwenye community na kwenye wazazi, we can move forward. Thank you very much, Otuk. And now I would like to welcome our second panelist, Dr. Isa from CCBRT. And I think we all know, kama tukiambiwa hospitali ambayo inatoa huduma kwa watu wenye ulemavu. I think hospitali ambayo kwanza tutaiongelea itakuwa ni CCBRT, right? And Dr. Isa, with that background, tungependa utuelezee what are some of the interface challenges between demand, that is client side, and supply, that is both provider and infrastructure related, of us SRH services. And what are some of the examples of adaptation that CCBRT has put in place to address this? Karibu sana, Daktari.
Yeah, thank you, Anna. So we have a lot of challenges actually from our end point. Generally, a lot of organizations, NGOs, have been dealing with the teenagers, have been dealing with people with disability from the community point. But now when it reaches to the level of service provision, that is where a lot has to be done. We still have a gap. We are left behind. Biggest barrier for now is infrastructure-wise. Most people with the disability are left behind from our infrastructure setups. Most health facilities are not very friendly for people with disability to use. You see, even when I was looking into the hall, we didn't have a ramp to even come on the stage. So how could Frederick, maybe if we want him to be up here, how will he be here? So we are not seeing this. We are forgetting them. I don't know if it's intentionally or we did not put a lot of focus on making sure that we don't leave anyone behind. So one of the biggest challenge is infrastructure and the social norm that my brother was talking about here. Leave alone people with disability, but also the teenagers and adolescents. By rate, we have a lot of numbers of young girls having pregnancy. But then with our experience, they come and seek medical attention or come for their regular antenatal clinic very late. Now, when we ask ourselves why is this happening, it's because nyumbani kwanza wanafichwa. Wow, they are not even free to tell their parents that they are pregnant. We are advocating a lot that nowadays any woman who is pregnant should come as early as possible to seek medical attention. But then kama hatuna huo muunganiko wenyewe vizuri na watoto wetu, majirani, watoto wa majirani, wanakuja wakiwa ujauzito una miezi 7. So they have already missed a lot that is needed to be done earlier on. And so the medical seeking behavior bado ina gap. Kwa hiyo a lot of effort inakuwa ipo huko, a lot of organization, jamani twendeni, lakini now the link ya kufika hospitali, it's still a gap. We need to do something on that too. But stigma pia bado ipo from the health personnel themselves. Wakiona msichana na miaka 14 amekuja na ujauzito, wanaanza kwanza kumsema, kama wanamshangaa. Kwa hiyo that also draws back these teenagers and adolescents to come to seek medical attention as early as needed. Poverty is another issue that cuts across both group, the adolescent part, but also the people with the disabilities. For example, most of people with disability are in the marginalized side, and hata kufika hospitali utakuta anashindwa, and we know people with disability movement yao pia sio rahisi. Kukimbilia madaladala ya Mbagala, it's not that easy. So kupata taxi from Mbagala maybe going to Muhimbili 10,000-20,000, it's not an easy issue if they can't even raise 3 meals per day. Kwa hiyo unakuta ni ngumu pia kuaccess kuja hospitali mapema. Tunatamani kila mjamzito to attend at least 8 times in hospital according to the Ministry of Health now, but then they will come only 2 or 1 time clinic that is needed to be accessed 8 times. Kwa hiyo we are missing a lot of screening to these people, and eventually we end up having bad outcomes kwa watoto wao. Kwa hiyo nayo pia ni challenge kubwa ambayo tumekutana nayo in a hospital base. So what has CCBRT done so far? CCBRT upande wa health wise imekuwa ikifanya makubwa sana, and it has an inclusive policy for people with disability. Actually, the national percent inabidi kila institution ama sehemu ya uajiri iwe na 3% ya watu wenye ulemavu. CCBRT is doing great on this. 6% of people, all employees of CCBRT, 6% are people with disability. So from this part tumewawezesha, ni wengi wamejichanganya na wanatusaidia sana kwenye maamuzi mengi ya kuhusiana kutoa huduma kwa watu wote wenye ulemavu. Lakini pia there are a lot of advocacy plans and trainings that are including these employees, of which are people with a disability, to advocate on service provision, to advocate others that they should seek medical attention, but they bring the barrier closer, iwe thin, kwa sababu wanatusaidia hata kwenye issues za communication with hawa watu wakija kuseek medical attention. Lakini tangua kitengo kipya cha uzazi kilipofunguliwa pale CCBRT, kime strategize purposely that we are welcoming teenagers, pregnant teenagers to come and deliver there. Na tumetengeneza like a system that all employees pale watakuwa wanapata training ambazo zipunguze judgmental issues should be well off. So we are receiving all teenagers that are pregnant, and they should receive equal and good health services as compared to any other woman, without any bias or any barriers. Kwenye people with disability too, we are including them, although of course I will declare we still have a challenge, especially kwenye hiyo party ya nauli wao wafike hospitali. So we purposely and intentionally tulitangaza wakati tunafungua hospitali kwamba wanawake wajawazito walemavu wanatibiwa bure. You just need to reach the hospital. Watoto wote adolescents wanatibiwa bure. You just have to reach the hospital, and other cadres, including people with bad outcomes, previous pregnancies. But now the gap now is there. How do they come? How do they reach there? Hicho kipengele ndio bado we are trying to see how we will help ukishikwa mkono of course with other organizations to see how will the transport issues for them to come and have the services when they reach to CCBRT. Lakini CCBRT infrastructure wise jinsi ilivyojengwa technically with a lot of ramps, but the beds are very supportive. Delivery beds, movements, they have special toilets for people with a disability. So it was purposely meant to be a center for people with a disability to come and have services and delivery at that hospital. Ile timu ambayo imeajiriwa, the 6%, it's helping us a lot in also communication. Tunajua we need a special communication to these people. So one, akiwepo mjamzito ambaye ana ulemavu wa aina yote ile, especially maybe kuongea ama kusikia, wao wanatusaidia kufanya hivyo. Kwa hiyo a lot has to be done. CCBRT is trying so much, and we have done so much in this field. We are hoping to do more, and maybe we'll hear some of other things to be highlighted from the team, which will pick them up and see how to improve from there. Thank you.
Asante sana daktari. So maybe I'm reflecting on Dr. Issa's point. Wote tunatoka kwenye mashirika mbalimbali. Tunaweza tukakadiria tuna asilimia ngapi ya watu wenye ulemavu kwenye mashirika yetu? Can we talk about 3%, 2%, 1%, 0? 0, yeah? So I think that's one point of reflection. I think that we should all take forward. We are also implementing different programs targeting different people. Can we think about how have we trained the healthcare providers to be able to attend to people with disability? Tumeambiwa kwenye population yetu 9.2% ni people with disability. How have we adapted in our program to also be able to reach this population? So, you know, na mwenzetu ameongelea kwamba as they have 6% of their employees being people with disability, they also support in communicating with other people with disability that are coming into the hospital. But also just saying, you know, kwamba people with disability wakifika watahudumiwa bure is also showing a gesture, a positive gesture, kwamba tunatambua wapo na tunataka kuwahudumia. So after that, I'm now passing on to my co-moderator to take on.
Asante sana Ana, na asante pia Dr. Issa kwa hiyo kazi nzuri ambayo CCBRT mnafanya. Sasa niende kwa Bisia Kabuje, Senior Social Welfare Officer from PROLAG. Kwako, baada ya kusikia some challenges ambazo Dr. Peter ameelezea, bado kwamba kuna issues za infrastructure, kuna issues za attitude, kuna medical seeking behavior kwa wale watu wenye ulemavu na vijana, kwamba bado ni changamoto. Sasa PROLAG, mkiwa kama the main custodian wa provide healthcare services to all Tanzanians in this country, what are the strategies that you have in place which are aiming to address the barriers that people with disabilities and young people face when they are trying to access sexual reproductive healthcare services? Mna mikakati gani kama wizara ambayo mmeiweka na mnaitekeleza ili kuondoa vikwazo kwa vijana na watu wenye ulemavu kuweza kuzifikia huduma za afya ya uzazi? Karibu.
Asante sana kwa swali lako zuri, na nadhani tumesikia challenges ambazo wenzetu watu wenye ulemavu na vijana ambavyo wanapata kufikia huduma za sexual reproductive health. Sasa the government, we have some of the strategies which we have put in place. For example, we have the improvement of infrastructures which have been built. For example, in every facilities, if you go to the health facilities, dispensaries, there are the improvements of buildings where even if the person with a disability have a wheelchair can pass to enter in the facility. But also in the toilets, we have special toilets for persons with disabilities. And also, we can find that some of the facilities have these youth-friendly corners whereby youth can go there and get some of information and services concerning sexual reproductive health. The other said one of the barrier is that is cultural practice, or which lead to the stigma to some of the youth and the person with disabilities. What the government have put in place, as we know, we have this national, we have different committees at village level or at mtaa level. We have committees for persons with disabilities at village level where they share different issues or barriers or challenges which are facing them, and then they present all those challenges at the specific persons. For example, if it is the concern of health reproductive, it is sexual reproductive health, it means they refer, we have those community health workers. The community health workers, they refer those issues or challenges to the specific professionals, if it is in the hospital or to social welfare officers. It depends on the challenges which all those youth and the person with disabilities are facing. So what we do, we have trained community health workers at village levels. According to our guideline, tuna hawa CHW ambao wao kazi yao kubwa, they identify those persons with disabilities and then they refer them to the facilities. Kwa mfano, wametusaidia sana kuhakikisha kwamba nini, kama kuna mtu mwenye watu wenye ulemavu, labda ni mjamzito, hajaanza kuattend kwenda clinic. Kwa wao kazi yao kubwa na identify na kumrefer haraka sana kwenda kwenye nini, kwenye kituo cha afya ili aweze kupata nini, huduma mapema. Hata hivyo kwa upande wa vijana. But the challenge ambayo ipo bado, person with disabilities, for example, we don't have this enough persons with sign language. You can find that kwamba mama ni mjamzito, hawezi kuongea, amefika kwenye facility na anakutana na mtu wa huduma, hawezi kufanya nini, kumsaidia. Hiyo bado ni challenge ambayo tuko nayo,
na nadhani hata upande wa CBRT kama alivyosema mwenzangu kwamba nini pale angalau wao wamewachukua wenyewe person with disabilities ambao wanasaidia kutoa nini huduma, lakini bado kwenye vituo vyetu vya afya kuna hiyo changamoto kubwa especially kwa watu wenye ulemavu ambao hawezi kuongea. Na nini ambacho tunakifanya, tunashirikiana na kiona kama kuna changamoto kama hiyo, tunashirikiana na wadau mbalimbali waliopo kwenye eneo husika kuhakikisha kwamba nini wanaenda labda kwenye facility na kuweza kutranslate. Na tukumbuke kwamba nini watu wenye ulemavu si wote ambao wamejifunza lugha ya alama. Kuna lugha ya alama ambayo mtu anajifunza tu nyumbani na mzazi wake, lakini kuna lugha ya alama ya nini ya darasani. Kwa anapoenda kwenye facility sometimes inakuwa ni ngumu sana kwa yule ambaye hata shule hajaenda ili aweze kupata nini services. So that is hiyo ni changamoto mpaka sasa hivi ipo na tunaendelea kuiface. Labda hapa sasa tutaona namna gani ambavyo tutaweza kujadiliana tuone namna ambavyo tunaweza kuisaidia. But another improvement is that access to information and communication was increased. Public health announcements information was presented in simple, easier understanding graph formats, information given by radios, television, demonstrating activities such as using condoms. Hata sasa hivi unakutani hata ukienda kwenye ofisi, sasa hivi kuna issues za condoms zinaweka kwenye nani, si ndio kwenye public toilet, si ndio Lakini lengo yote hiyo ni kwa kama alivyosema stigma. Kwa sababu ukiweka mahali wakwambia nini, yaani mtoto huyu ana miaka 12 anakuja kuchukua condom. Lakini kama alivyosema mwenzangu kwamba nini, hata kama tusipowaambia lakini unafanya, si ndio Sasa what to do? Kwa bado tunawatumia community health workers kuhakikisha kwamba nini wanatoa elimu katika jamii level, kuhakikisha kwamba nini wana access all these issues ili sasa waweze kujikinga na magonjwa ambayo yanawafesi vijana wetu lakini na watu wenye ulemavu. As I said, we have youth-friendly corner were established to some of the health facilities to ensure sexual reproductive information and services are provided by observing confidentialities. Sometimes unaweza ukaenda kwenye facilities kama walivyosema wenzangu, kuna baadhi ya watu wa huduma wana abusive language, si ndio Mtoto anaenda pale kweli ana tatizo, anatakiwa apate huduma, lakini anapokuta ile mtu wa huduma lugha anayomtolea, yani wewe mtoto mdogo wewe ndo unakuja kufanya hiki, unaona. Kwa wale watoto walikuwa wanaogopa kwenda kwenye nini, kwenye vituo vya afya, lakini kwa sasa hivi kumekuwa na hizo corners na vijana wanaenda wakiwa, kwa sababu wale watu wa huduma wameshafundishwa namna gani ya kuweza kufanya nini, kuwahudumia wale vijana bila kuweka nini unyanyapaa. Another issue is the community HIV education on GBV, VAC programs was provided at village and mtaa level by community health workers to youth and persons with disability through their forums. Kama tulivyoona kwamba nini hao watu wenye ulemavu na vijana, kutokana na mila na desturi, nadhani ameuliza kaka pale, ni wangapi kulingana na mila na desturi zetu sisi, wewe umekaa na mtoto wako wa kike au wa kiume, unamwambia masuala ya nini, masuala ya sexual reproductive health, ni wangapi tunafanya? Tunasema ni mila na nini na desturi, si ndio ndani nakutani ni wengi hatujafanya hivyo kwa watoto wetu, lakini ukikaa pembeni ndio anatumia simu, anatumia means nyingine kuhakikisha kwamba anapata hizo nini information. Sasa siku ya siku tunakuja kuhakikisha kwamba ni mtoto kashaharibika, lakini kumbe ni sisi wenyewe wazazi hatakuwa nini friendly kuwaeleza uhalisia, kuhakikisha kwamba nini wajue viungo vyao, wajue kwamba nini mimi nimeshakuwa ni kijana na napaswa kufanya nini, na nikifanya hivi na niletea 1 2 3. Lakini tunaona aibu, si ndio kwamba wewe mtoto wangu wa kiume unajua ukifanya hivi na hivi utafanya nini, utapata magonjwa ya STD, si ndio au mtoto wa kike utapata mimba, lakini hatuambii. Kwa hiyo matokeo yake sasa nini, hivi vinapelekea sasa watoto wetu kujiingiza kwenye makundi ambayo sio, na matokeo yake sasa ndio wanapata magonjwa mbalimbali kutokana kwamba hawapati light informations na pia akipata hilo tatizo anaenda kupata wapi huduma. Na kwa wale ambao tunafanya kazi kwenye vituo vya afya tumeshaona kwamba ni watoto wetu wanaokuja wengi wa kiume, wengi unakuta ni especially watoto wa kiume, unakuta ni wana thamani kwa wanaume mliopo ndani. Watoto wengi wa kiume hawaoshi, hawafui boxer zao zile, si ndio? Wengi hawafui. Sasa wanakuja unakuta wana fungus. Lakini sisi wazazi tuko nao, unamwona mtoto wako yuko smart, lakini you can't give any information maswala nini? Haya maswala ya usafi. Matokeo yake mtoto anakuja kupata magonjwa, yani ndio anavyozidi apata nini? Anapata magonjwa. Hata watoto wa kike the same apply. Kwa nini mtani nini? Sisi wenyewe kwamba ni vijana wetu tunawafundisha nini? Kwa sababu tunasema mila na desturi haziruhusu. Lakini je, mila na desturi haziruhusu mtoto wako kumwambia vitu ambavyo kwamba nini? Baadaye vinamletea manufaa asipate madhara baadaye. Kwa hiyo kinachotakiwa tunaendelea kutoa elimu na kuwafundisha community health workers kuhakikisha kwamba nini, wanakaa na vijana wetu, wanakaa na watu wenye ulemavu, kwa sababu sisi wazazi tumeshindwa kuplay part yetu, si ndio? At least wale community health workers wao wanatoa elimu. Kwa hiyo wanakuta ni wametusaidia sana kuhakikisha kwamba nini, vijana wetu, watu wenye ulemavu wanapata information kwenye masuala ya sexual reproductive health. Lakini also we have these clubs in schools. There are different clubs in schools, na mashuleni kule wakutani wanafundishwa haya masuala. Although kwamba si wanafundishwa kulingana na umri wa nani wa watoto na upevukaji. Kwa sababu si kila mtoto ana darasa au yuko nasari unaanza kumfundisha masuala nini ya reproductive health. Kwa hiyo wanafundishwa kulingana na age na maturity, na wao wenyewe waweze kuelewa, waweze kujitambua namna gani waweze kupata hiyo elimu ili waweze kuwa vijana wazuri baadaye. Na issue nyingine ni issue bado serikali inaendelea kuajiri watumishi wa kada ya watu wenye ulemavu vijana. Hata kwenye ajira sasa hivi mmeshaziona, sasa hivi watu wenye ulemavu sasa hivi wengi wameajiriwa, na hata hizi za afya ambazo zimetoka juzi tumeona watu wengi wameajiriwa na wamekuwa posted kwenye vituo vya afya, ambao tunategemea kwamba hawa pia watakuwa ni chachu ya kutusaidia sisi wakati wakipata watu wenye ulemavu kwenye health facilities. Thank you.
Asante sana madam kwa ajili ya maelezo yako mazuri ambacho ni nini serikali inafanya. Labda wakati tuna wind out improvement wanazoifanya kwenye infrastructure, hebu angalieni standard zikoje, na masuala ya communication information nayo ni mambo ambayo yatahitaji kuangaliwa zaidi. Je, viziwi na wasio na wanapateje taarifa za afya? Niende kwa dada yangu Fatuma Usi kutoka Zanzibar. Yeye ni Information Education and Communication or Behavior Change Officer kutoka Ministry of Health Zanzibar. Swali langu kwako ni kwamba being as a provider of strategic direction to sex delivery provision, can you share with us some examples of policy guidance that Zanzibar has put in place to ensure that inclusive services are provided to people with disabilities and to young people? Mnaweza mkashare na sisi mifano ya kimiongozo ya kisera ambayo Zanzibar imetekeleza kuhakikisha kwamba vijana na watu wenye ulemavu wanapata huduma rafiki? Karibu.
Thank you very much, moderator. Before that, to say example, I want to say something about the ministry. Ministry of Health Zanzibar has been implemented their strategies and the policies is the same as Ministry of Health mainland, with focusing in providing curative and preventing. The sexual reproductive health in Zanzibar with disability program under the Jumuiya ya Walemavu Zanzibar, we plan and conduct training. During the training we involved the peer educator in the program of education on sexual reproductive health, and a life-saving program to help the disability adolescents in the provision of sexual reproductive health, ensure that they are able to get a session and knowledge during session and outreach. Outreach is done in school, out school, and the community. So I want to share the example of how it's work in Zanzibar with young people and people with disability. The healthcare center providing the service with regardless of their status. Also, the ministry is able to build the RAM every health facility in order to accessible the healthcare service and also people with disability to move in and out in the health facility and to provide health care. Also, the young people and people with disability have access to providing and receiving health information and education, also counseling concerning sexual reproductive health. Also, the revolution of Zanzibar and the collaboration with partners for all renovate the 12 YFS Center youth-friendly service, all in district in Zanzibar, Unguja and Pemba. Vituo hivi vya YFS Center youth-friendly service au tunasema huduma rafiki ni vituo ambavyo pia educator wamejitolea, wanakwenda katika vile vituo, wanawafundisha vijana wenzao, wale vijana rika. Pia tunapata supported na donors, tunawapa training wale pia educator, so wanakuwa more educated kuwa educate wenzao ili wapate kujinusuru na yale mambo hatarishi. Also, Ministry of Health to ensure availability of IC material available in the health center and the youth-friendly service. Example, leaflets, posters, booklets. Mfano tunavyo pale vipeperushi vinahusiana na huduma rafiki kwa vijana, ijue huduma rafiki kwa vijana ni nini, usafi wa hedhi kwa wasichana. Hivi tunakuwa tunafundishia na tunawapa during outreach session au tunapokwenda katika kuelimisha katika vyuo vya university na shule za sekondari. Pia tuna vipeperushi vya uzazi wa mpango kwa wale wanachuo, tunapokwenda kuwapa education tunaenda tunawapatia, lakini pia tunavyopeperushi vinavyohusiana na huduma uzazi wa mpango na baada ya mimba kuharibika. Also, service provider help the young people for sign language. Kama tunavyojua wakati mwingine wanakwenda wale ambao wana mahitaji maalum au disability, hawezi kuongea au hawaoni. Kwa hiyo service provider have knowledge how to communicate those people in order to provide care and anything that they come to the facility to provide. Asante sana.
Asante sana. I think Fatima ametuelezea strategy ambazo zinaendelea Zanzibar, na anasema zina tofauti sana kati ya Zanzibar na mainland. But I think one important thing that I would also like to highlight ni different models ambazo ana mention za kufikia young people. Kama tulivyoongelea mwanzoni, kuna issue ya access kwenye upande wa huduma kwenye vituo. Lakini je, can you use other platforms kama vile outreach? But also I highlight an important point regarding partnership ambao wanafanya kazi na wadau. And I think that also stages us very well with the next speaker, Dr. Moke, is a community partner, from INGO. And we know partners also play a very big role in service provision. So what lessons can you share from gender health in programming for young people and people with disability? Karibu daktari.
Asante Dr. Anna. I will share some few examples. One, we have learned that young people or people with disability, they are not homogeneous. When you are told these young people, the need for a young person 10 to 14 may be different from the one with 15 to 19 and even above before they reach their 24 years. So you need to tailor your intervention. Huduma zile unazowapa inabidi utambue hicho. One of us recognize it. Nafikiri ni Dr. Isa alikisemea hicho. Kwa hiyo katika programming yetu tunahakikisha kwamba makundi haya yote tunaya accommodate. For instance, it was mentioned here, mtu mwenye aliye na uziwi anapokuja to seek services, the need of such person when it comes to effective communication is different na mwingine mwenye physical disability. So that's one lesson na program zetu zinajaribu ku accommodate that. And the second thing is that the country still faces a critical shortage of skilled providers when it comes to provision of disability-friendly inclusive services as well as inclusive services for young people. You will note that the majority of providers have been supported largely by partners. The resources put forth from within the system is still limited. As a result, you find that the target, if I'm not mistaken, by 2025, we are supposed to have reached 80% of West facilities being adolescent and youth-friendly services. And I'm not very sure if we are anywhere near it yet. So as partners, we need to continue supporting training of such people. However, there are some challenges on that too. At times you train people, after a few months or after a year, they are transferred somewhere else to do something at times unrelated to what that person was trained for. Kwa wale wanaojua the system of Tanzania, hasa wauguzi, you know rotation. When it's a time of rotation, they don't even consider this is the key person here, possibly the only key person with these skills. If we transfer her or him somewhere else, who else is available to provide such services? At times you go to his facility, you find that the services are not being provided because of such undertaking. Another thing we have learned over the years is that especially when it comes to people with disability, the S system doesn't have tools to capture the information. What you don't count, you don't remember. As the that goes. We are managing to capture information on people with disability based on our own program tools. And as a result, we are already concentrating collecting information from our outreach, whether we have a leeway of collecting this information. Systemically, you can't capture that information reliably. Tumekuwa tunashauriana na mikoa, CHMT na HMT, wakashauri kwamba kwa wale wanaojua register, the FPA register, you record at the comment column if somebody a disability, so that you have that information. You can imagine the level of reporting when that is the mechanism. Another thing we have learned over the years is meaningful youth and people with disability participation in programming ensures increased uptake. What people don't know, they are likely to follow. It's even more challenging with the two groups. If young people understand that the environment is not conducive for them to seek services, they will hardly come for such services. And you will only achieve that if they are meaningfully engaged. We engage them in our services, and as an organization of almost 1 million clients we get through our various SRH services, almost 16-20% are young people. And of these, over 40% are young people aged before becoming pregnant. you know the challenge we are having with the girls becoming pregnant, teenage pregnancy in this country. We are one of the countries on the continent with the highest level of teenage pregnancy. And it's only through that where you can address such issues. And lastly is the investment. We have learned that unless you invest in the youth and people with disability, don't expect to reach them meaningfully. By this we mean when you invest for them to realize that you are a partner with them, they are likely to follow what you are providing. You are seeing in this room some of our stakeholders. We have various groups. And if you are not intuitive to understand that dynamics can be different, at times you don't even recognize them. For instance, if you go with the Washington criteria for categorizing people with disability, they don't categorize our colleagues with albinism, like my young sister there. And at times, based on our services, people are discriminated based on other conditions, not only albinism, other skin condition. Somebody with severe vitiligo, sijui neno la Kiswahili linakuwaje, mtu anakuwa na mabaka, or even severe psoriasis. Such a lady or a woman will seek service and na wewe naye, and you too, as if that person is not supposed to receive SRH services. So again, unless you invest to understand such issues, you are unlikely to have a program which is comprehensive and inclusive enough to engage these people. Thank you, Dr.
Asante sana daktari. Kabla tujapongeza panelist wetu, naomba ni ongelee kitu cha mambo daktari ameviongelea. Na naomba ni anzia palipoishia, investment. We need to invest. Kitu ambacho kila mmoja anaongea anasema makundi maalum. Lakini makundi maalum is a very broad term. Hata ukisema pia watu wenye ulemavu, pia it's also a broad term. Sindio, kwa sababu kwenye kundi la watu wenye ulemavu bado kuna mahitaji tofauti kwenye hilo kundi. Kwa hiyo bila kuinvest, you don't expect to get any results. And that also invest in a big terms. Kwa mfano, mwanzo kwanza aliongelea, how do we bring young people on the table? And it's not just about bringing them on the table, but it's also for you to accept na kupokea maoni yao. But how do they get there? You also have to invest kwenye huyo mtu ambaye umemleta kwenye meza leo. But I think another thing ambacho ningependa pia kuongelea ambacho Dr. amekiongelea hapa ni skilled providers. Tunaongelea sana training, lakini tuna train on the same things vile vile bila kubadilisha, kuchange as a need be. Lakini pia when we transfer, yes, skill transfer itatokea. Tuna skill transfer is not bad. Lakini as we transfer, have we prepared kusababisha huduma iendelee? But nadhani ni slogan kubwa sana kwenye wizara zote na kwenye supervision yote utakayoenda, wanasema what is not documented is not done. Sindio? Tunaongea kila siku. But now let's look at our tools. I think wote tumeelezea kwamba tunafikia watu wenye ulemavu, tunafikia young people. Yes, young people we are able to capture them. But are we able to capture young people with disability in our routine services? To know kwamba kweli tumewafikia. Our HMIS tools do not capture that. What are we doing and what? Na uzuri na shukuru pia wenzetu soka Pioragu hapo hapa na naomba pia uweze kulipokea. Tools zetu is not capturing. Nimependa from Pioragu asema kwamba sasa hivi pia kuna employment kubwa pia imeenda kwa watu wenye ulemavu. Lakini are we also noting kwamba ni asilimia ngapi ya hiyo employment inaenda pia kwa watu wenye ulemavu? With that, asante sana daktari. A round of applause please to our panelists. Na pia ninawashukuru sana kwani wote mmetunza muda. Tulikuwa tuna dakika 10 per person lakini ilikuwa ni our time for 7 minutes na wengi mmeweza kufika hapo. Kwa hiyo asanteni sana. Sasa tuna open up the stage, lakini kabla hatuja open up naomba niwakaribishe watu wachache Frederick, kama una chochote ambacho ungependa kuongelea, and then we'll go to our colleagues at Pathfinder ambao tuna implement now mradi ambao daktari alikuwa anauelezea, kama you have anything to say, and then we'll open up for questions.
Yeah, asante sana Ana na panelists wote kwa ajili ya highlights na presentation zenu nzuri. Mimi ni endelee kusisitiza jamani kwamba watu wenye ulemavu, kuwa na ulemavu haina maana kwamba hawaishi maisha ambayo mtu ambaye ana ulemavu anaishi. Wanakuwa na familia, wanazaa, wanakuwa na watoto, wanakuwa na majukumu mengine kama mtu mwingine yote. Kwa hiyo kama development actor, unapotengeneza program yako, ukisipomjumuisha huyu mtu ni kwamba umemwacha nyuma. Na haya maendeleo endelevu ambayo tunataka kuyafikia, hatutaka tuyafikie. Msemaji wa mwisho ameeleza masomo ambayo mmejifunza kutokana na mradi ambao unatekelezwa. Niwaombe kama wadau, na ninazungumza sasa kama mtu mwenye ulemavu, kwamba jamani, tukumbukeni kwenye program zenu, na tuna msemo kama watu wenye ulemavu kwamba nothing for us without us. Hakuna ambacho ni chetu pasipo ushiriki wetu. Sisi kama watu wenye ulemavu ndio tunajua ni kwa kiasi gani viatu vinatubana. Ukitushirikisha tutaweza kutoa mawazo na kuona namna gani tunaweza kushiriki kutatua changamoto zinazotukabili ili sote tupate haki kwa mujibu wa taratibu na sheria zilizopo. Kwa hiyo naamini ukitoka hapa utatoka na mtazamo chanya wa kuona kwamba ninafanyaje programu yangu ili iweze kujumuisha vijana na watu wenye ulemavu in a meaningful way, kama ambavyo wasemaji wamesema. Fungue sasa milango kwa wote, sasa mweze kutoa michango yenu, kuuliza maswali, kama ni clarification, tumia lugha yoyote ambayo utaona inafaa kwako, basi uweze kupata mawazo yenu ya namna ambavyo wawezeshaji panelists wetu wameweza present. Kadadana.
Asante sana Fred. Una swali?
Dada kama kuna mkono.
Ile mic.
Dada hapa kuna mkono wa Rabia, atazungumza nasi kupitia mkalimani.
Sawa, asante. So kabla Rabia hajaongea, tulikuwa tumeongea pia tutawakaribisha partners wetu Pathfinder. Karibu sana.
Asante sana, habari za mchana. My name is Joseph from Nigeria. I'm the country director for Pathfinder in Tanzania. And Pathfinder is a partner in the program which is being discussed now. We are consortium members, and the reason why Pathfinder is part of this program is to lead on the implementation of different youth interventions, making sure that youth are able to access services. A lot of things have been discussed, and we are quite proud, to see, some of these interventions and the innovations that Pathfinder has been leading on are bringing fruits, are bringing results. But I just wanted to highlight two or three things which I think are critical from the lessons we have taken from, the different innovations that Pathfinder has been doing in this program, in other programs in Tanzania, but also beyond Tanzania. Number one, there is a lot of stigma around young people getting services. There are so many barriers that young people go through before they reach the service delivery point, but they usually face the last mile barrier, which is usually the bias from the providers who are providing services. And that is regardless whether somebody is having disability or is not having any disability. Provider bias is a critical issue in enabling young people to access services, and Pathfinder has been doing a lot of innovations around tackling, provider bias against serving young people. We recently closed a randomized controlled implementation research program, which was done in Tanzania here, but also in Pakistan and Burkina Faso. And we are measuring different innovations, that can be implemented to make sure that we address the provider bias. And we implemented innovative interventions, like we had a provider summit, we had rewards, and digital connect for providers, which proved to be very, very innovative and very, impactful. Another thing which I wanted to mention in relation to, stigma, Pathfinder has been implementing the values clarification and attitude transformation for providers. People have different values as we stand here. My values may be because of my religion, my values may be because of my background, my values may be because of my profession, and because of those values, I feel uncomfortable to provide family planning and other sexual reproductive health services to young people. So we have been integrating, incorporating values clarification concepts in all trainings which are targeted to provision of youth-friendly services. There is a national curriculum for youth-friendly services, but we have been augmenting it with value clarification concepts to make sure some of our providers can address some of the struggles they have because of their values. The third thing I wanted to mention here is, like adult people, young people also have multiple needs beyond sexual reproductive health services. They also need income generation. Some of them have issues related with gender-based violence. Some of them may need legal services, and so on and so on. So it cannot be, the health sector alone cannot resolve all the needs of young people. And because of these other issues that are surrounding them, they have negative impact on their ability to take up sexual reproductive health services. And to be able to address that, Pathfinder came in with an innovation, which is we call it collective impact groups, CIWG, where in an area where we are implementing, we look at different partners who are doing different interventions targeted to solve young people's, and then we come together and we see how we complement each other, in the work we do. Related to that, Dr. Mokin said very correctly, we say young people, 10 to 15, or 15 to 20, or 24, but young people are not homogeneous. They are a very heterogeneous group. It makes a huge difference whether I am a young person living in the urban area with my counterpart who is living in the rural area, or if I am a young girl who is not pregnant compared to a young girl who is already pregnant or already has a baby. So because of the special needs of girls who already have babies, and my colleagues can support me, most of the young people who get services, they end up getting it when they are already pregnant. You may reach young people, but when you look at them, most of them are already having the first baby. So Pathfinder has been innovating in implementing programs which are targeting first-time parents, young people who already have babies, and that approach is looking at, helping them to do healthy timing and spacing of the second pregnancy, but at the same time, helping them, to get other services beyond the sexual reproductive health. So that's the cocktail of interventions that Pathfinder has been doing in Tanzania and beyond to make sure that, young people have access to these important services. Thank you so much, Madam Anna, for giving me the audience.
Asante sana daktari. Sasa naomba nikaribishe yale, kulikuwa kuna mikono 1, 2, 3, 4, mikono 4. Pale miwili, 1, 2. Okay. Karibu. Mike, naomba Mike yasia hapa. Okay, anauliza swali atatafsiriwa na mkalimani.
Asante kwa kupata nafasi hii. Kwa majina naitwa Labia Abdalla, anazungumza kupitia mkalimani. Mimi mwenyekiti shirikisho la vyama vya watu wenye ulemavu SHIVYATA mkoa wa Dar es Salaam. Ni mwakilishi, nimekuja kwa ajili ya watu wenye ulemavu. Nimeangalia hapo kwa panelist mambo mazuri ambayo umeweza kutuwasilishia, lakini nafikiri bado hatujafikia malengo. Kwa baadhi yetu, kwa hasa kwa watu wenye ulemavu. Tumezungumzia vijana kwa kiasi kikubwa sana, lakini ukiangalia ndani ya vijana pia kuna vijana wenye ulemavu. Tukiangalia upande wa pili, CCBRT wamezungumzia kuhusu upande wa ajira, na akazungumzia kwamba ajira na masuala ya vifaa ni vitu viwili tofauti. Ajira na kibarua ni vitu viwili tofauti. Kuna ajira na hizi temporary job ni vitu viwili tofauti, hasa katika upande wa huduma za afya. Kweli tumeona watu wanazungumzia masuala ya huduma za afya, lakini utekelezaji tunaweza tukasema bado hauko sawa. Kwa mfano sisi watu wenye ulemavu wenye uziwi, tunapopata masuala ya kujifungua kunakuwa na mchakato mrefu. Kuna mama, kwa mfano mimi ni mama mwenye watoto 3. Mimi nikibeba ujauzito miezi hadi 6 ndio unaweza kunigundua, lakini mimi mwingine naweza nikakaa hata miezi mingapi, 3, ukakaa ushaona tumbo limeshatokeza. Sasa kwa mtu kama huyu ataanza lini na masuala ya matumizi ya kondomu au vifaa vingine anakuwa hajui. Anakuta kujishtukia tu tayari keshapata ujauzito. Kwa hiyo changamoto kubwa sana huja katika upande wa mawasiliano. Mara nyingi unapofika hospitali unakuta na muuguzi anakupa hizi dawa, anakuambia utatumia hizi dawa. Sasa uliza hizi dawa mbona zipo nyingi, nichague ipi? Lakini unakuwa hujapewa maelekezo, inakuwa ni changamoto katika kutumia zile dawa. Vile vile katika upande kipindi cha kujifungua unakutana na muuguzi unapofika leba kama mama kwenda kujifungua unakutana na muuguzi ambaye anaongea na kuita labia njoo. Mimi sisikii. Nasubiri uchungu umenikamata, kumbe ananiita labia kwa sauti, mimi sisikii. Mwisho wa siku nakutana napoteza mtoto. Na mimi nikofikia hapo nikasema sitoweza kuzaa tena, siongeze mtoto tena. Kwa mawazo yangu naweza kufanya hivyo. Na asante sana, nafikiri niongee kwa haya machache.
Asante sana. Asante. Naona mmempigia mwenzetu makofi, lakini ametoka kutuambia changamoto yake. Kwa hiyo naomba tumfanyie. Yes. Asante sana. Tunashukuru sana kwa Labia kwa kushare experience na kwa maswali ambayo nadhani panel yetu imeipokea. Kulikuwa kuna mkono right next, karibu.
Okay. Jamani, habari za saa hizi? Hongereni panelists, mmefanya kazi nzuri, mmewasilisha vizuri, na naomba niwape tu hongera pia kwa hatua mbalimbali ambazo mmefanya kwa ajili ya kusababisha tuendelee kupata huduma, hasa katika hili eneo la service provision, katika eneo la afya. Nipongeze juhudi zote zilizofanywa, lakini naomba nijielekeze. Nimesahau kujitambulisha, samahani sana. Jamani, mimi naitwa Madam Udageja Manonga. Ni katibu mkuu chama cha watu wasioona. Sasa naomba niende moja kwa moja kwenye eneo zima la ujumuishwaji wa watu wenye ulemavu katika kutengeneza ama kuandaa programu zetu mbalimbali katika vituo vyetu mbalimbali na maeneo yetu yote tunayotekeleza shughuli zetu za kila siku za muda mfupi, muda wa kati na muda mrefu. Ni hivi, changamoto tunazo, na kwenye eneo la swala zima la uelewa, bado uelewa wa baadhi ya watu bado ni mdogo kuhusiana na watu wenye ulemavu. Jitahidini muda wote kumtaka mtu mwenye ulemavu ajieleze zaidi yeye mwenyewe kuliko kumharakisha ama kumharakia yule aliyemsindikiza. Yule aliyenisindikiza mimi wala hata hana majibu na changamoto, wala hata hajui changamoto yangu nilionayo. Nazungumzia nini? Eneo la usiri. Kama mtu mwingine, mgonjwa mwingine yeyote, ana haki ya kuwa na usiri wa changamoto yake ya kiafya. Hali kadhalika mimi nami nahitaji usiri huo. Kimtaka sana msindikizaji wangu azungumze kwa niaba yangu, mimi unaninyima nini? Ile haki ya usiri. Tunaelewana jamani? Haya, lakini jambo jingine, Kwa mfano kwetu sisi kina mama tusioona, of course napongeza juhudi zinazofanywa na serikali kwenye hospitali zake. Hata sisi BRT mnafanya vizuri sana, mnaruhusu tuingie leba na wahudumu wetu, lakini jamani, wakati mwingine wengine wanasahau, wanakataa taratibu hizo. Tunapohitaji huduma hiyo mturuhusu, kwa sababu uwizi wa watoto jamani si upo. Sasa mimi najilindaje na hilo eneo la mwanangu nisimpoteze? Kimsingi sizungumzi tu hadithi za Bunuwasi, iliwahi kunitokea hiyo, lakini kilichoniokolea mwanangu ni swala zima la mimi mwenyewe baada ya kumpata mtoto. Anyway, huwa na tabia simruhusu mwanangu achukuliwe kabla mimi mwenyewe sijamfanyia touching. Lazima nipapase mtoto wangu nimuelewe, ndipo mchukue. Sasa kitu kilichonisaidia, sababu nilimdai nikarudishiwa mtoto wangu, na kabla sijamridhia nimemtachi kwanza, ndipo nikamuelewa kwamba yes, ndio yule mtoto wangu nilie ondolewa, kwamba akasafishwa kwa ajili ya kwa ajili ya hatua zingine tu za usafi wa kawaida. Sasa unadhani ni kila mama mwenye kutokuona ana capacity hiyo? Anaweza asikumbuke, na hata kama akikumbuka, kuna circumstances mbalimbali zinazoweza kusababisha mtu akashindwa kuchukua tahadhari hiyo ya kumuona mtoto wake ama kumtambua mtoto wake kwa namna wezeshi alionayo. Lese amepoteza fahamu, lese amefanywa pengine operation ambayo haijampa yeye fursa ya kuweza kumaccess mwanae vizuri. What will happen? Kwa hiyo ni muhimu wasaidizi wetu tuliowaamini sisi wakaruhusiwa, madam hakuna sheria ama kanuni ya kiafya itakayokuwa imevunjwa kwa msindikizaji wangu mimi kuambatana naye. Sawa jamani wakubwa?
Sawa Thomas.
Haya, jambo jingine inapokuja maswali jamani, funguzeni yale ambayo hayana akili, lakini maswali yenye akili hoji yote. Usipohoji yote ukapata ufahamu, utaendelea kuwa mshamba. Wakati mimi nakuhitaji uendelee kunihudumia. Tunaelewana wakubwa zangu? Msijizuia kuhoji vitu ukajifunza, ukajua. Sasa kwa mfano nimekuja nina venereal diseases pale. Kuna changamoto gani? Kwani kuna ubaya gani ukiniuliza? Nilipata pataje? Huyo mtu ni nani? Naishi naye au kashaniacha? Ili uweze kumuokoa, kuendelea kuniokoa kwa kumuita huyu aje naye atibiwe. Kwani kuna dhambi katika hilo eneo? Lakini ukiniambia sasa maskini Mungu wewe mwenyewe huoni umepata kaswende nitapata kwa sababu mwili unawaka tamaa na uhitaji mwanaume. Kwani kuna dhambi? Mnisamehe kwa kuzungumza jamani, mimi nimeamua kuwa frank, sawa eh? Hakuna tamaa inayompata mtu mwenye ulemavu ambaye inazidi kuliko ya kwako. Tunaelewana wakubwa? Wewe unapata hisia hizo kwa sababu unakula vizuri, si ndio? Lakini nani nakula vizuri, si ndio? Sasa kwa nini watu kama itofautiane kwa sababu nina disability? No thank you. We do running under the same sun. We do working under on the same one. Well, si ndio jamani? Okay. Sasa lingine naomba nizungumze hivi. Kwenye hizi tools mnazotumia kwa ajili ya data collection katika ngazi za vituo vyenu vya kutolea huduma ni nzuri jamani, mnazo. Sasa ni hivi, boresheni tu, muongeze kipengele cha nini? Disability. Kwa mfano jina la mtu mwenye disability, aina ya disability, alafu na level ya disability. Tumeelewana jamani? Sio mbaya. Unaweza kupata sa records za watu wako ama hudumia wako vizuri. Sawa jamani? Kaboreshe tu hizo. Siko vizuri, wala zina tatizo. Lakini kitu kingine, jamani, kuna vitu tunaombea jamani, kama naombeni mkubali kushirikiana na sisi. Tunavyo vyama vya watu wenye ulemavu. Kwanza tuna SHIVYAWATA, shirikisho la watu wenye ulemavu. Ile imecombine vyama vyote vya watu wenye ulemavu. Tunaelewana jamani? Aina kama 10 hivi. Kama una haraka kuna muda kutuzungukia sisi wote au mtu mmoja kama kundi, basi ioneni SHIVYAWATA, watawapa ufafanuzi wa mambo mengi kutuhusu sisi. Sawa jamani? Lakini ikija kwenye specification, vyama vyetu vipo kwa ajili ya kutoa ama kushirikiana na ninyi kuwapa updates pamoja na mambo mbalimbali, tushirikishane ili tuone namna njema ya kuendelea kuwahudumia watu wenye ulemavu kulingana na disability tulizonazo. Sawa jamani? Ukweli uliopo ni kwamba kila mtu ndiye anayejua uhalisia wa disability yake, lakini pia namna ya kucapture attention ya disability yake mwenye disability ndio anayejua. Tumeelewana jamani eh? Usifanye chochote kinachotuhusu sisi pasipo sisi, tutafutane. Tunaelewana jamani? Mungu awabariki. Lakini pia kama kunakuwa na misconceptions zozote zile ambazo pengine mimi kama muda nitakuwa nimesababisha, usichukulie kwamba ndio misconception tulionayo wenye ulemavu wote. Hizo ni individual. Si ndio jamani? Karibuni sana. Bila wapenda bure.
Okay, naomba tupokee moja tu ili itakuwa la mwisho, na hatutajibu, tutazipokea zote kama comment alafu tutafunga.
Kimsingi sina swali. Kwa majina naitwa Maria Chale, natokea Shivyawata, shirikisho la watu wenye ulemavu. Matatu amenifilisi jirani zangu, nashukuru kwa kuwakilisha vizuri. Naomba niongele. Mimi naomba niwaze pamoja na wadau wetu watoa huduma kwa watu wenye ulemavu kwenye upande wa afya. Mazuri imetufanyia, tunasema asante, lakini bado ipo haja. Sawa, kuna kamati mpaka naundifundisha kamati za vijiji sijui, lakini hao watu wenye ulemavu walioko kwa vijijini wanajua. Shangazi yangu kule Manda anajua. Ni vitu ambavyo naona bado vinahitaji kuongeza nguvu. Lakini nilichotaka kuwaza na nyinyi, je, ni vipi serikali ikaamua katika vyuo vyote vya watoa huduma ya afya ikaongeza mtaala wa lugha ya alama na lugha ya alama mguso? Hii itasaidia, asante kwa support. Hii itasaidia hata kujibu hoja aliyoongea baba yangu pale kwamba eti unamfundisha mtu, unampa ujuzi and then anapata transfer, lakini akiwa amefundishwa kutoka chuoni, I'm sorry, hata huyu atakaye kuja kukava nafasi yake atakuwa
It talks about quality of healthcare in Tanzania, the status and areas of improvement towards achieving Health Sector Strategic Plan number 5. So, Government of Tanzania, in partnership with PATH, today we would like to deliberate how digital technologies and data contribute to overall efforts to improve healthcare for all Tanzanians. The session today will help to amplify the successes and outlines areas that need some efforts and investment. The idea is, how do we work together to digitally transform Tanzania's health sector? So, in today's session, we'll start with 2 presentations, and then I will introduce the panelists who will come in front for Q&A. Then we'll invite questions from audience. Before I proceed, I would like, first of all, for you to know who is standing in front of you. My name is Henry Mwanyika. I work for PATH as Acting Chief Digital Officer, but also I'm Digital Health Regional Director for Africa. And I'm quite honored to be a moderator of today's session. And I'm looking forward to hear from presenters, panelists, and also I would like to encourage you, after every single presentation, please reserve your questions so that we can ask later on presenters and the panelists some questions. So I'll start with the first presentation. So the first presentation today will be presented by Taunga Chilalika. Taunga is a South African-based policy and advocacy officer. He's a colleague who works for PATH. For our advocacy and public policy team, her day-to-day role is she assists African countries in the region, including South Africa, to design and execute advocacy strategies to advance policy and advocacy goals in areas such as global health, research and development, and regulatory strengthening in the region. She's been leading and coordinating a dual project, data use acceleration project, where she was leading data collection across 5 countries on how these countries worked together in their countries to digitally transform their health systems. So she'll be presenting today about ideal approaches to digitally transform. So ideal approaches for digital transformation. We'll be very strict in terms of time so that to avoid also taking time in the next session. So she'll provide some highlights on key elements for successful digital transformation based on practical experience in 5 countries. And these countries are Tanzania, Malawi, South Africa, Ethiopia, and Burkina Faso. And are meant to inform digital transformation efforts and decisions by global and country policies. Without further ado, Taonga, please, welcome.
I'll use this.
Thank you. Good afternoon, ladies and gentlemen. Habari za mchana. I've been taught that that's the right way to greet, and it's really an honor for me to be able to present to you on the dual approaches for digital transformation in health. I'll be sharing some findings from a project that we've been doing over the past 2 years, as Dr. Henry has said, across 5 countries, and it's really more of an opportunity to share lessons learned through those 5 countries. And before going to the actual presentation, just to give you a little bit of an overview that in order to capture some of the lessons learned from these 5 countries, we've spent the past 5 years or so, the past 2 years or so, in 2 phases of the project. The first phase was more focused on desktop review. Then after that, we really spent some time identifying key informants from the 5 countries and interviewing those key informants to be able to share what I'm about to present today. By way of background, the name of this project is the Data Use Acceleration and Learning Project, and in short, we call it the DOE project. And the purpose is really, it's an initiative that aims to share what works to achieve digital transformation, as well as what does not work based on the experiences of these 5 countries. So when I'm referring to the 5 countries, these are the countries in which we worked in, the 5 focal countries, including Burkina Faso, which was done in partnership with the implementing partner of Cooper Smith, in Ethiopia with JSI, in Malawi also Cooper Smith, and of course in Tanzania with some of our colleagues that are in the audience today was Tanzania. And then in South Africa, it was a collaboration with the University of Cape Town, based in the Western Cape province. So essentially this dual toolkit that we developed for digital transformation can be used by a range of stakeholders. We've tried to outline the different stakeholders in this particular slide, from implementers to countries to funders as well as to policymakers, both at a global and regional levels, and funders including those from the private sector operating at both the regional as well as a global scale to assist in collaborating together with country governments to digitally transform their healthcare. And when we're looking at from an implementer's perspective, it's really trying to advocate for digital transformation at country level. And when we go all the way down to the policymakers, it's more around advocating for increased standardized guidance around the best practices in digital transformation and data use. In our efforts towards developing this particular model, as many of you may know who are in the digital health space, there are several models and frameworks that currently exist, everything from the DUP theory of change to the PRISM model to the WHO National E-Health Strategy building blocks. And what we found is that currently many of these frameworks and models are often high level, but most importantly, the gap that we saw was that they don't take into account the country experiences and lessons, which is what we aim to capture across these 5 countries. So in summary, this is currently what the model looks like. It evolves from the WHO and International Telecommunications e-health strategy building blocks, and it's key factors for success that can be applied across different countries, irrespective of their digital health maturity levels at any stage of the process. And really, it's meant to help not only aligning finances, but also aligning policies and future investments. So you'll see the way in which we have structured the model. We really have right at the center community members. That way we want to make the biggest impact is to support ourselves as community members, and we have that surrounded by the workforce. Across the 5 countries, we really heard from our implementing partners as well as country governments and other key informants that the health workforce is right at the center of successful digital health transformation. And then we have, after that, we have the data use ecosystem, which looks at everything from data analysis, data collection, and data management. If you are familiar with the previous models, you will know that data use ecosystem is currently not there. And based on our analysis and our key informant interviews, this is a new element that has been added to the e-health strategy building blocks. And also we have change management. I will go into the data use ecosystem as well as the change management in a little bit more detail in subsequent slides. And then we have the surrounding elements. In total, there are 10 of them. We're looking at everything from leadership and governance. I know my colleagues that are working directly with the Ministry of Health have quite a lot of experience around leadership and governance, and I'm sure they're quite happy to share a little bit more around that if we during the Q&A session. Then we have strategy, we have systems architecture, services and applications, infrastructure. Of course, in the context in which we work, infrastructure is not always fully developed, but it's not at all a limitation in stopping us from implementing digital health transformation models and projects or implementing strategies within the developing infrastructural system, where things such as connectivity may be a challenge, but I think there are a lot of innovations that are being developed that can cater for such. So across the 5 countries, we made the effort of documenting the lessons learned across the 10 elements of the model. And in as much as I may not have enough time to go through each of the lessons learned, maybe I can just pick out 1 or 2 to share with you. For example, for leadership and governance, we found that it was really important to remain flexible in shifts in government. I have a particular example that I'll be sharing shortly around the Tanzania implementation work that speaks specifically to that point. Around investments, one of the key lessons that we learned was that it was important to develop funding oversight mechanisms. Again, I'll be sharing an example that's specific to Tanzania. And as I've said previously, it's really important for the health workforce and for us to be increasing data use at all levels of the health work system, all the way from the bottom or so-called lower levels of implementation and work, all the way through to the top areas within the health workforce systems. As I've mentioned, that data use ecosystem and change management are the new additions that are very specific to this particular model that we've developed. And I'd like to just take a few moments just to go specifically into more detail around the data use ecosystem. So we saw that a robust data use ecosystem depends on a cohesive and aligned systems architecture in which systems connect and share data collected from multiple sources. Of course, when we're operating in this environment, interoperability is very important, and I think gone are the days when we're developing systems in silos that are no longer speaking to each other, and we're moving towards that level of implementation where different data systems can actually talk to each other and feed off each other's information. And without this architecture in place, data remains siloed, and we end up contributing to the duplicative nature of data collection efforts, which is something that we are trying to avoid in this area of work. When we're looking at change management, we know that while much work goes into the planning and the technical aspects of digital health transformation, oftentimes there's less consideration to how change will affect the health workforce. And what we are advocating for is for change management, especially around enforcing changes in how operating standards, which is really important towards the implementation of our digital health strategies. So again, change management is one of the elements that is newly identified and very particular to our dual model. So I hope I didn't rush through that, but I wanted to give you an indication of what the model currently looks like, and just to re-emphasize that it's those 10 essential elements that are almost the ingredients that country governments, implementing partners, funding partners, and all the other players and stakeholders in this field can really take from to advance the digital health transformation landscape. And I'd now like to go into very specific examples that are specific to the work that we did. We've partnered with the government of Tanzania on the data use partnerships around some of the elements of the dual model that I have shared. So for example, in looking at the area of workforce, and this one is particular to building capacity for future digital health landscape. We saw that as a result of this capacity building initiatives, this was a e-learning platform for health workers, as well as updating curricula to include data use skill sets. We saw that health workers, especially in remote areas, who previously traveled long distances, benefited significantly from this particular e-learning platform. And additionally, it also helped workers to evolve from just being data collectors or coming in only at the beginning to being users of actual data themselves. Another example that I can share from our work with the Tanzania Ministry of Health is around fostering digital health champions, both within and outside of the health sector. So engaging multi-sector partners raises awareness of digital health interventions and increases their uptake. For this particular initiative, the Ministry of Health and PATH established a project governance unit. I know that we have a panel discussion a little bit later on that will touch on this specific on this element a little bit more. And as a result of this project governance unit, the Ministry of Health and beyond helps to secure buy-in, which is really important, and is also quite important as it links to the next slide that I'm sharing, which is around accounting for change in government leadership. I think it's one of the things that in the implementation of our work in Tanzania, there were several changes in leadership. And as changes in leadership across different countries are inevitable, it will happen at one point or the other. And it often brings shifts in priorities, it brings shifts in management, and shifts in structures, shifts in staff, all of these elements that can affect project timelines and how we implement our project, and can sometimes slow down activities. So it's really important for us to be developing sustainability plans that take into account these changing government landscapes or changing in leadership. So that's another example that I'm happy to share with us. That was a very key lesson that we learned specifically from the implementation of the work in Tanzania, as well as the work across the other 4 countries, with the main emphasis of really we need to be nimble. We need to be flexible to accommodate these shifts in government. But most importantly, we need to build sustainability plans. Another example that I would like to share with us that was quite important towards building successful digital health transformation strategies and projects was around building flexible digital health strategies. We recognize that a strategy is only beneficial if it is operationalized, and the implementation team, which was worked together with the government of Tanzania, also helped socialize the strategy amongst various stakeholders, including donors and partners, to ensure that the country's strategic goals were aligned for future investment. And as part of that strategic planning process, there was also the development of the roadmap, the investment roadmap. The current one is the 2017 to 2023, and I'm sure I do believe that there is a revitalization of this particular digital health investment roadmap, and I'm sure my colleagues from Tanzania can speak a little bit more on this particular strategy. But it was quite important that the roadmap helps to ensure that current and future digital health investments support the current strategic goals and the vision. If you looked in through this right-hand side of the hall, you would have seen the mission and the vision clearly displayed on one of our promotional materials that are outside. And it's really important for us to be able to prioritize this with the finite resources that we do have. So just a few cross-cutting call to actions. I'm going to run through these calls to actions quite fast. One is that it's very important to engage stakeholders in leadership. Two, it's very important to design health systems that are user-centered. We want user-centered design systems. We want to strengthen governance structures. And this could be everything from having technical working groups embedded within the ministry, taking working groups that are outside of the ministry, hybrid technical working groups. And it's also important for us to increase evidence-based planning and to sustain funding. So I have just 2 more slides and I'll try to wrap those up quite quickly. I think I am coming close to time. But we had specific call to actions that were for country governments, for our government colleagues that are in the audience, that is quite key to establish governance structures. I think I'm repeating this over and over again, and it's just really to emphasize that point and drive it home that we need that in order to enforce digital health policies, guidelines, and standards, and also towards the investment of roadmaps, supporting technical working groups, cultivating champions, as well as motivating our health workforce. We know they are super tired and inundated, and they're really working as hard as they can, and we need to do as much as we can to keep them motivated. And then just just 3 more actions to take from a policymaker perspective, everything from developing guidance and promoting adoption of the 2 elements of the data use acceleration and learning project, in particular change management and data use ecosystem, and also to encourage the development of investment roadmaps in order to accurately budget and scope digital health transformation models. So this is really a snapshot of this particular project that we've been implementing over the past 2 years, which is the Data Use Acceleration and Learning project. We have various resources, including our website that should be launching soon. We have our dual report, which is also currently available for sharing, which goes into further detail around every single one of these elements, how they can be used by different stakeholders. We have fact sheets as well as case studies, which I'm sure would be very happy to share with anyone that's really interested in this particular level, this particular work. But other than that, I'd just like to take a moment to appreciate you for spending 15 minutes of your time listening to some of this work that we are doing, and I'm happy to answer questions later on in Q&A, as well as with support from my colleagues from here. And yeah, so asante sana, and thanks for allowing me this opportunity.
Thank you, Taunga. One of the key messages that I got from this presentation is that whatever we do, the core is about the impact. And in health, the impact is about community. How do we ensure we have healthy communities? So everything we discuss, digital transformation, digital technologies, at the end of the day, we need to see that impact in the community. The second presenter, we heard about the work that was done in 5 countries. So now we'd like to hear Tanzanian journey when it comes to digital transformation. And our second presenter today is Sostenes Bagumhe, who is a human-centered design expert with over 13 years experience in information system project management and implementation, working with the Ministry of Health. He has contributed to developing and deploying state-of-the-art ICT systems at national levels. Currently, Sostenes is leading the implementation of client registry, as well as integrating tertiary hospital systems with DHIS2. And for years, he's been overseeing implementation of Health Information Mediator, which is a key component of health information exchange for Tanzania. Sostenes is currently chair and founder of Tanzania Health Informatics Association, which creates a platform for knowledge sharing among ICT and e-health experts in Tanzania. So Sostenes, he'll be presenting today about highlight of how Tanzania has applied this digital transformation efforts in the journey. Sostenes, 15 minutes, please, sir.
Documents.
Good afternoon, ladies and gentlemen. My presentation title is Highlight of Tanzania Digital Health Transformation Journey. The government of Tanzania, which includes pure large means of health, recognize the importance of digital health in transforming the healthcare delivery. We have overseen the digital health journey from 1999 to date. Let's see the journey before 2010, how digital health in Tanzania was. In this period specifically, we focused on digitalizing the information collection in the health, such as the NHS2 and care for treatment cards, database for HIV. And in this period is a period whereby we introduce the ICT section, the means of health, which is dedicated for overseeing the implementation of digital health in the country. Between 2011 and 2020, we came to the point that we realized that in the last period, 2021, before 2010, it was characterized by donor-driven projects, which were bringing about a lot of duplication of efforts and resources. So this was a call for action to introduce the governing structure to oversee the implementation of digital health and control the duplication of effort and resources of partners and the other digital health key players. So in this coming period of 2021, 2010, we focus on the effort to introduce the governance mechanism and the structures to connect the digital health journey, and then other issues which were emerging in this period. We introduced major state-of-art and legal system in the country, such as ELMIS, DHS2, and supply chain digital tools like ELMIS, VIMS, and EPICA9. And also, not forget the point of care system like GoToMIS and AFCA in the government. Let's see the 2021 to date, what was happening. In this period, we established the blueprint, interpretation blueprint, which is a tool for establishing guidance and standards which ensure interoperability of systems across the sector. And in 2021, the government rapidly maintained the foundation which was obtained in 2021-2010 to make sure that we continue to enhance these digital systems in a coordinated manner. Where are we heading? where are we heading in terms of the health sector? This will be a vision. The vision which leaders the better health outcomes through digital and enabled health systems. And how do we maintain this vision? Is by coming up by the mission that we reach to this vision by accelerating and transforming Tanzania healthcare system through innovative, data-driven, client-centric, efficient, and integrated digital health solutions. And we come up with some strategic goals. I just mentioned the two of them, which is strengthen digital health governance and leadership, which is the key for coordinating the partners and digital health initiatives. And also improving client experience through efficient provision of healthcare and quality health services. What are the achievements which we have achieved? We can just mention, I just mentioned up the few key achievements which we have achieved. The first achievement, we established the digital health governance mechanism and structure to oversee transformation of digital health journey. This is coming up with the ESTN committee and the AEICT and ETWG, which oversee and coordinate partners and the government in pertaining to the initiatives which are being developed in the country. Another key achievement is to strengthen the availability and use of health supply data through digitization of commodities and logistics management. For instance, I can give you an example. We have more than 7,000 health facilities in the country. To supply health commodities, medicine, medical supplies to 7,000 health facilities, it's difficult. You don't have timely data and quality data. So through ELMIS, for instance, each facility is requesting and requisiting these commodities from MSD. And by the tip of the coin, MSD receives this data and supply those commodities to these facilities. Another achievement which we have incurred in the implementation of point of care systems, including EMR like AfriCare and GoTMS to the PHC. These were basically controlized the hospital operations in health facilities, both from tertiary hospitals and PHC. Another key achievement, we improved the use of data in key sector administrative management functions, including planning, financial management, supervision, and performance management. I can just mention some of the tools which were each used in these three major areas. Like on the planning, we're using PlanLab. And the financial management, we use MOSA and FAST. And the performance management supervision, we use FSS. The last key achievement is being about the information exchange of data by coming up with a health information mediator which assists systems to talk to each other. And by this, it saved the philosophy of collecting data once and using it multiple times in such a way that once you collect data of health facility registrations in the HFR, health facility registry, and once you need the source of waste facilities or legitimacy of waste facilities, you don't need to collect it twice. You just link with the waste facility registry and pull the data regarding the waste facility. Another key advantage of this health information mediator is save the cost. Instead of collecting data twice, you just collect once and use it multiple times. And another advantage of health information mediator, it creates the source of truth of data in such a way that you can rely on, let's say, FARA as the true source of truth regarding the data of waste facilities. The notable gaps and challenges. We do experience and we do recognize that we have one bit of individual level data at national level, which can support effective monitoring for surveillance. By saying so, by policy, we are not required to create. We are not advised to pull individual level data from SOC level to the national level. And by practice, we just pull aggregate data to national level. But we do limit some issues like the monitoring and contact tracing of, for instance, a person who was inquired infectious disease. And for instance, he has inquired infectious disease. At the national level, how do we deep dive those information and data to deep dive and come to the individual level data so that we can use this data for contact tracing and surveillance and monitoring to save the disease not spread to other people. So those are gaps which we do have. Another gaps which we do have in the ability to uniquely identify health service clients. I can give an example of this. For instance, in Tanzania, for about 10 years, we've been receiving the support of LRV in such a way that other countries like Congo and the other countries don't receive the support of LRV. So there was a practice, we just recognized that the truck drivers from Tanzania to Congo and the other countries, we don't receive LRVs, the support of LRVs. Once they leave the Islam, they go to CTC clinic and they take the LRV dose. And once they come to Pani, they say they take LRV dose. Until they cross the border from Tanzania to Congo to other countries, they've taken more than 30 doses of LRV. What is the repercussion? The repercussion is when you order the LRV in the country before the year, we order it annually. And we order it in accordance with the number of LRV patients we do have in the country. So with these trends, you can find a junction that we are going out of stock before the year ends. So with this, how can we solve this? By introducing identifying client uniquely identifying your clients. For instance, fingerprint of client registry. But we recently recognized this, and the government is addressing this with very great emphasis that they've introduced the national client registry, which uniquely identify clients to maintain this solution. And another gaps with the inadequate coordination of partners, which result to the reduction of effort and resources. Another gaps was inadequate resources to support the implementation of the priority areas in the strategy and a digital health investment roadmap. For instance, the first health investment roadmap, about 60 to 70% of it was just implemented because the 30% was not attached because of lack of resources. Looking into the future, how do we envision the future? By improving coordination investments, implementation of digital health initiatives and systems. And another point is to mobilize resources to support implementation of the entire digital health investment roadmap. And also document and share lessons locally and globally from Tanzania digital health transformation journey. And another point which we envision into the future is continue implementing the change management strategies to sustain the digital health investment. The change management strategy ensures the successful transition of different projects from the end of the project to be adopted by the government. So by also this, we have another point, which is advocate the data use across all levels for evidence-based decision and actions. And so by this, we just make sure that, because when we recruit doctors, nurses, and the others, when they came to the work area, most of them they don't have the skills and knowledge for data use. So we have realized this, and we have introduced on the pre-service and in-services curriculums the skills taking the skills of data use and the data use to the curriculum of in-service and pre-services. Also for the e-learning for doctors and nurses which are on their daily works. Thank you for listening.
Thank you, Sostenes. And I think key takeaway message here is that partnerships and coordination is critical in any digital transformation journey, and also is beyond technology. He talked about the importance of governance, but also change management is a critical component of any journey. So the two presentations has set the stage. And to be honest, I'm really, really honored to be moderating this panel of distinguished panelists. And I'm still shaking now as I introduce each of these. They have vast experience. So the first one, I would like to introduce Dr. Grace Magembe. Is a medical doctor. She currently serves as Deputy Permanent Secretary, President's Office, Regional Administration and Local Government. Dr. Magembe is a public health specialist with 20 years experience in managing health systems at national and subnational levels, in both curative, preventive, and also promotion. She has vast experience in advancement of policy agendas. And I'm quite honored to introduce Dr. Magembe. Please take your seat. I would also like to introduce Dr. Saif Shekalage. Dr. Saif Shekalage is Deputy Permanent Secretary, Ministry of Health. She's a medical doctor, and she has a master's in public health and PhD on malaria transmission. She has extensively experienced in malaria transmission and conducting epidemiological and intervention studies, including MDAs, mass drug administration, using different antimalarial drugs. Please, Dr. Saif Shekalage. Another panelist I'd like to introduce is Dr. Saif Rashid. He's a public health specialist with expertise in health planning, project management, health financing, monitoring and evaluation of health-related interventions. He served as a Minister for Health and Social Welfare at the Government of United Republic of Tanzania from 2014 to 2015, and where he directed development of our first e-health strategy and guided National Health Insurance Fund to work towards universal health coverage. Dr. Saif, please. Also I'd like to introduce the doctor in the making, Eric Kitali. Eric is the Director of ICT and President's Office, Regional Administration, Local Government, since 2015. He's a certified enterprise architect and a key player in designing, developing, installing, commissioning, and supporting countrywide ICT enterprise level systems. He oversaw the integration to the development of systems, including integrated financial management system, EPICO, used by all 184 LGAs, and GoToMis, used by more than 1,500 health facilities, and other systems used by local government authorities. He oversees the ICT infrastructure network that connects 184 LGAs in all those 26 regions. Dr. Eric in the making Kitali, PhD candidate, please take your seat. Do we have extra microphones so that to avoid transferring of microphones, because we have limited time, unfortunately. Thank you, and again, I'm quite privileged and honored to be sitting next to this distinguished panel. And I have a few questions that I will pose to the panel for their responses. Let me start with Dr. Saif Shekalage. We've seen the highlight of Tanzania digital transformation journey, including where we've come from 2011, and to where we are, and the vision for the future, where we are going. So I would like to understand from your perspective, what does successful digital transformation mean to Tanzania from health domain perspective? Dr. Seif Shekalage.
Thank you very much, Dr. Henry, and glad to be here. Yes, transformation has taken place in the healthcare system, and I just want to highlight on few issues on how this transformation has taken place, especially in the area of the quality of the information that we are receiving, but also in terms of the evidence-based from the data that we're using, but also in terms of the efficiency. So what it means when I'm saying the quality, we are seeing now the transformation in terms of the available data, the data that is being accessed by the people in the healthcare system from the different variables, the burden of the diseases, healthcare delivery. These are of quality, high quality, compared to where we came from. We have seen from the second presentation before 2010 how the situation looks like and the journey that we have started in 2021 as we go forward. Now we are witnessing high quality, the data that is available that people are accessing. So this is transformation that we have seen. But when we talk about the evidence-based, what do I mean? Now, when we are doing our planning, our budgeting, but also our policy making, we are relying on the evidence of the data that is available. We are doing the timely intervention. From the data that we collect, we are able to plan very well and also to plan our intervention. So meaning that the transformation has taken place as we are now able to use the available data with the evidence. If we plan for a certain intervention, we are sure this is going to work because of the quality of the data that we have collected. So we use the evidence. But when we mean about efficiency, the efficient it means now we have used the available data to improve even our healthcare delivery. The time around the time of the patient going to the clinics, now we are sure it's a certain period of time once the patient walk in, and then after certain minutes or hours, will be able to walk out. So we have transforming the time around the time of the patient coming to the hospital, but not only this, also in other healthcare delivery, meaning that we have timely data, we have improved our efficiency in terms of the delivery of the healthcare, but also services, healthcare services. I'm also want also to provide evidence on the surveillance. Now with the digital introduction, we have integrated also into our surveillance system. So we are collecting data timely. We know exactly here, wherever the information is being collected and is put into the digital system, we can access it here. We know exactly how many numbers of the cases in a certain other disease, and then we are able to do any intervention. So these are just few examples that I've highlighted. But if we talk about the transformation of the digital, this has done a lot in the healthcare system. And I would like to, maybe I'll come back again later to give more examples. But now to start with the rolling, I think let me just end here. Thank you very much.
Thank you, Dr. Shekalage. I'd like to turn to Dr. Magembe. You have vast experience in preventive, curative, and also promotion. And, you know, when you talk about digital transformation, it's not an end to itself. So, but is a way, is means to improving quality of care for Tanzanians. Based on your vast experience, Can you share with us examples of health areas where digital health has successfully helped improve and areas where digital health is falling short?
Yeah, thank you, Henry. Good afternoon, everyone. Maybe just a very small observation. Next time your panel should have more women as well. Yeah, so that's out of this panel. Okay. So thank you for inviting me, and let me just take up from where my colleague here, Dr. Saif, left. But well, I'm a pure medical doctor. I'm not an expert in IT, ICT, whatever you name it. They have their jargons, you know, and digitization, all those. So initially, you know, the health sector has come a long way. So when we heard about digitization of the health system, what came to my mind as a medical doctor? First, I was like, yes, service delivery will be improved, right? Patient waiting times and stuff like that. And then I was like, I think this is the time now, I'll just sit somewhere in my little clinic or my office and I just press a button. It shows me how many patients have come to a particular facility, what was their problem, what was the diagnosis, you know, how much commodities do I have, what is it short, what is falling short, what is what. So that's what I was thinking. But also in terms of managing other resources, including finances, but also the whole concept of good governance, because there's no service without good governance, okay? But again, what came to my mind was like, okay, I'll be able to manage my human resource. I know who's where, doing what, how many hours they've worked, what have they done since morning to this time. But I was like, now we'll have real-time information for decision making, planning, resource allocation, and decision making, not only to, I'm not talking about ministries and stuff, no, but from the healthcare provider, where the information is being collected, right? Do these people understand what this information tells them? Can they really make sense out of it? How is it helping them to plan, to forecast, you know, and such things? So in some areas, yes, things have happened. But Dr. Saif shared some examples. I don't need to go into that. He shared some examples. But what I'm seeing as a fallback is that most of these innovations, they are still in patches, in silos, verticalized. They've not really addressed the entire health system. So you find it's a system for malaria, for HIV, for TB, for what, as if the entire country we are suffering from HIV or malaria. So somehow my expectations are not being met, have not been met, okay? But even today, when you go to our facilities, it's so surprising to find our staff. They are overwhelmed with huge books, huge volumes. They feel this and that and this and that. I mean, I thought this would have been one way of reducing the workload from our staff, so that they can concentrate on technical issues rather than, you know, concentrating on these data and stuff like that. So again, we have so many systems that are not communicating. I like that word of yours, interoperability. I hope I pronounced it. It took me some months to practice that, so I'm happy that I've managed it. Okay, so can these systems, these various, can they speak to each other? Because what I'm looking at is, as a healthcare provider, when I'm seated in my facility, in my clinic, okay, I don't have to feel this and that and this. My responsibility is to see a patient. So whatever information I'm getting from whichever system, information that I'm collecting from whichever system, let the systems communicate. And don't ask me for information, you come and ask me for this, you come and ask me for that. It's quite disturbing, you see. So yes, we've made progress, but to me, we still have a long way, especially in improving the quality in terms of service delivery, okay? But in terms of harmonization of all the systems that we have, so that they can speak to each other. But again, seeing that, scaling up all those systems and innovations to address a bigger proportion of the health sector rather than concentrating on few interventions or few programs as the situation is now. Thank you.
Thank you, Dr. Magembe. And interoperability. Thank you, you got it right. Thank you for that. And I think you mentioned something very important, is that, yes, we need to make sure that data use, not in isolation, in silo, but how do we ensure that we can have an impact across programs at the facility level. So, Eric Italy, I would like to come to you. When you sit down with technical people and also you hear policymakers like Dr. Seif and Dr. Magembe, they talk about their vision. And we realize governance is a critical component of ensuring that digital transformation is successful. What is your current view of the status of digital health governance mechanism in Tanzania?
Thank you, Dr. Henry. Good afternoon, all of you. Leadership and governance must be overemphasized. And I thank you, Taonga. Taonga, you mentioned it very well in your dual model. Even in the theory of change of DUP, we have the leadership and governance there. But also the WHO health building blocks, we have leadership and governance. Without leadership and governance, all the issues which my boss, Dr. Magembe, raised here on the challenges, information sharing, interoperability, reducing the waiting time, the quality service delivery, we can't reach that and we can't achieve that without leadership and governance. And in Tanzania, we have done so much. One, we have a national level steering committee taking care of all the digitalization. Not necessarily health sector, but all different sectors. And the National Steering Committee is chaired by the Chief Secretary in Tanzania. And it is very stipulated in the E-Government Authority Act of 2019, Act number 10 of 2019. Down there, after the National ICT Steering Committee, which is chaired by the Chief Secretary, we did have a technical committee whereby all director of ICTs and director of ICT from the ministries, from MDAs, ministry, department, and the agents are meeting on quarterly basis. That one is also very well stipulated in that act, E-Government Act. And down there, we do have institutional steering committee. All those forums are helping us to ensure the leadership and governance towards the digitalization, healthy and other sectors is well achieved. Now in the health sector domain, we do have a national health steering committee chaired by Permanent Secretary and co-chaired by Permanent Secretary, Minister of Health, and co-chaired by Permanent Secretary Tamisemi, President of his regional and local government. That one is to ensure we are aligned with whatever which is stipulated in different policies like health sector strategic plan number 5. And down there we have a technical committee. So all these forums are there to ensure everything which we are doing, we are meeting the expectation of the business side, business experts, Dr. Magembe, Dr. Seif, and others here. That's number one. We do have the forums, and the forums are working very well. The thing which are, yes, down there we have a technical working groups. It is within the health sector strategic plan 5, and its technical working group number 10 is for digitalization. And I welcome every one of you to make sure you are participating in the technical working group number 10 for digitalization. In that particular technical working group, everyone is there to discuss to discuss different initiatives which you have in relation to digitalization. And here we are discussing all the core systems, as my colleague has mentioned, but also the value-added services which you can just come up from different startups and others. So once maybe if something has been done by the government, we are welcome to assist us to make sure whatever which has been done at the national level is reached the last mile, the community, the facility, and others. So we have the forum as far as leadership and governance is concerned, and we do have the different standards and guidelines which have been released by the government in collaboration with different partners. And one of the standard and guideline which you have is the Health Information System Guideline. I don't know if most of you have seen this one. This one is very well stipulating how are we going to share various information from different systems which you have, the way we are developing the systems, the interoperability which Madam Magembe mentioned here. So we have documents like this, we have health strategy, health digital strategy and others. So that one is also helping us to ensure the governance and leadership is overemphasized in digital transformation. The last one are the tools. We do have tools which we are taking the inventory of all the systems which we have. Tools like inventory systems, we have system for GISP, which is hosted by IGA. So here, as far as systems are concerned, we are taking the stock of all the systems so that it will be easier for us to oversee, monitor, and see how best we can work together to make sure the digitalization agenda in Tanzania, and especially in health sector, is achieved. Thank you very much, Dr. Andrew.
Thank you, Eric. So let us shift gears a little bit. We've heard about the impact in the health. We've heard about governance. Now, in any digital transformation effort, at the end of the day, is about data. And data not only at national level, policymakers, but all levels of the health system. There's one phrase that data should not defy gravity. It goes up, it doesn't come down. But now, how do we change that? Dr. Saif, what can be done to revolutionize the culture of data use?
Good afternoon. I'm so happy to be with you. This is a special session of digital transformation and to see where Tanzania stands. Ideally, I think during the presentation, Sostains did highlight to some, at least 2 or 3 points referring to data use components and how Tanzania has been doing to influence that and increase that aspect of taking the scenario that we do have a system that is, health workers, when they work, they produce the generated data. And when it comes that you have a digital system supporting that work, that comprehensive work of healthcare providers, it makes the data to be available in real time. And what can be done so as people, healthcare workers, can make use of that data that is constantly generated. There are 2 things one Sosten said. One is saying for those who are in service, healthcare workers who are in service, they've created some component using from the platform of e-learning platform to influence, orient, train, put even the videos, clips, and so on to encourage the know-how of the data and encourage the use of the data that is generated using the e-learning platform. But then for those who are coming new, you know, the new healthcare workers, you know, from the colleges, universities, and so on, there's a need to really look into the curriculum and make appropriate change so as the curriculum for healthcare workers incorporate aspect of the data use. But then in other areas, there is a need to do something more than the training workshops and so on. You need to build a system whereby, you know, good enough, we have a PSC here, Deputy PSC, Proporage, and Deputy PSC, Minister of Health. These are the guys whom we expect to ask questions and call for, you know, things like district profiles. When the district health management team prepare the annual, you know, they go through the data and they prepare their district health or council health profiles and the regional health profiles. It calls for people to start using the data because there is someone is calling for it, is asking for it. If the data is there and nobody is asking for that, nobody will prepare. At the end of the day, it is not ideally used. Even we need to look at the facilities. You know, health facilities, normally people work in their health facilities at the end of the year, they don't even know how many patients they've seen. They don't know how much consumption of some of the products that they've used over the year, and so on. Now, if they're asked to prepare a profile on how they fare on the previous year, definitely they will start using the data. But then the component, as you all know, we use data for decision making. We use data for planning. But at the same time, we need to incorporate and to put some test in the using of the data. Why? Because if, for example, our training institutions, they will recruit, you know, healthcare workers as they do working, then they can be encouraged to do operational research. They'll start using the data, and that will give back to them, and they will start be motivated because it is some career development benefiting for that. And therefore, for operational research, it's very important to be encouraged for the healthcare workers to use the data and to start making sense of the data that they are generating every year. I know there is every one of us knows that every place that healthcare workers do work, or any person that is working, there is a component of monitoring, evaluation, and reporting. All these really goes on together. Therefore, the production of report, supporting monitoring of issues that are happening there, from the product, from the healthcare workers themselves, from the consumption, from the disease burden, and so on, is really a key factor that would motivate and ensure that healthcare workers use the data that they generate appropriately. I think that is, in short, there is a lot of more interventions that can be done to promote healthcare workers to use the data that they generate in a good way. Thank you.
Thank you, Dr. Saif. I'd like to come back to you, Eric Kitali. So we all know that the government came up with investment roadmap that outlines areas that, if invested on, will change the way digital technologies are utilized in Tanzania. So, Eric, how is the government positioned to ensure that whatever is outlined in the investment roadmap is implemented in order for Tanzania to achieve its digital transformation vision?
Thank you, Dr. Andre. That's a good one. We do have a PHC digitalization roadmap document. My boss is here. But it's about to be signed, and within that document, there are some areas which we think And we believe once done very well, if we do it very well, it will get the sustainable impact on the health outcomes. Number one, partnership. We have issued this partnership within and even outside the government. So we are emphasizing there the partnership, and within partnership, we would love to see the co-designing of any initiative, the co-design, the co-development, the co-implementation of any digital initiative. That will help us to reap the benefits of digitalization and get the sustainable impact of whatever which we are going to do. Another thing on partnership is people integration. You know, most of the time we are referring to interoperability, we are referring to system integration. But if we don't start with people integration, system will never integrate. So we have to make sure we are integrating as far as partnership is concerned so that our system will integrate. So that's number one. Number two is the Kaizen principle. This is Japanese phrase whereby we believe on continuous improvement. If you have come up with my model, for instance, a human robot, and you find this robot has no ears, please come with the ear and not tell me this particular robot is no use. You know, once you have a system, you know, there is this issue for learning curves, using the system. So coming up with different system and changing that one which you have already used and having different learning curves is a bit difficult. So we are believing on continuous improvement, the Kaizen principle. So once there's any challenges or any gap within whatever we are doing, you are welcome to improve together. And that's the idea of co-design, co-implementation coming. The third one is monitoring, evaluation, and learning. Dr. Steve said monitoring, evaluation, and reporting. So once we monitor and we evaluate, we have to learn. And once we learn the gaps. If we learn the gaps, we see how best we can come up with initiative to fill the gaps. That's number three. Number four, the last one, is let's love our own products. Tupende vya nyumbani. We do have several systems which is homemade, like the Plan Rape, the Afya Care, and other startup systems. If we love our own Tanzanian systems, which we made for Tanzanians to cater for Tanzanians, you know, if you bring a system from abroad, okay, very well, working fine, but there is a cultural issue within that. There is infrastructural issue within that. When we build systems in Tanzania, we take care even the resources which we have. We build a system which can be used in, I don't know if we do have a place called Antalamba, somewhere there at the remote. So we build the system based on the resource which we have in Tanzania. So let's love whatever we are building, and let's see how best we can bring up our junior and senior experts. Thank you very much, Dr. Andrew.
Thank you, Eric. Co-develop, co-design, co-implementation is critical. Before I invite the audience, I would like to pose one question to Dr. Seif Shekalagi, but I will start with Dr. Magembe. The government is investing a lot, time, resources to make sure that all these digital transformation investments are successful. But they need to be sustainable. So how do we ensure sustainability of these huge investments that the government is making when it comes to digital health?
Okay, so it's true. A lot has been done, but we must have a mechanism of making sure that it is sustained. So one way is whatever initiatives we're putting in place, they have to be institutionalized. Yeah. And talking of institutionalization, you know, we're talking about issues of guidelines, okay? So that whatever we know today, I mean, where we are here or we're not here, those who are coming after us will really work into our footsteps. But the other thing is resources. Resources, and this particular area I'm talking about financial resources. And here, well, the government, we have a role to play as well, but also our partners who are here. Okay, so this one actually requires both of us, the government as well as our partners, to make sure that we allocate resources in this very important agenda. And the other thing is we must, I think this is related to what Eric just said, we must build our internal capacity. Okay, so I'm glad that we have a number of courses nowadays from various universities, and we have homegrown, experts who are coming from our universities and stuff. Some of them are going to study abroad, but really we need to invest in our people. So we need to develop enough skills and maintain them. So actually, I think these are some of the few things that I think really make all these initiatives that we have done, we've achieved so far, to be sustainable. And I'm happy that a lot has been done so far. Yeah, so I think we need to continue with that energy and making sure that, we put more resources. Yeah, thank you.
Thank you, Dr. Magembe. Dr. Shekalage.
Thank you. I think Dr. Grace, she has mentioned most of them, but I think two which I want to overemphasize is one, proper exit of projects. We are collaborating with partners in their different projects to starting the platforms. But now when they exit, there should be proper exit of those projects to ensure that once the partners are exiting, the local people remaining will be able to take it forward. So this is really important, because it should not end like once, if Path was supporting on everything and then support leaves and then the project collapses. So there should be a well-planned exit of that project. This is first. But second, now, because this is very important, we should include in our budget, if there's any resources that are required to make sure that the digital health is continuation, then we should allocate in our budget, yearly budget, that to be able to finance some of the activities. But another issue now is to continue on collaboration. This should be overemphasized. We need to still partnership, collaborating to build the capacity of our people so that they can continue on this agenda. So I think these are 3 points that I wanted to add on top of what Dr. Grace she has mentioned. Thank you.
Thank you, Dr. Shekalage. So I'd like to invite briefly a few questions. Please make them short, if you can. Straight to the point, and we'll invite the right individual to respond.
Yeah, thank you so much. My name is Otuk from Young and Alive Initiative. I only have 2 questions. One, how do we factor in issues of data security through the digital transformation? I know healthcare, especially health data, is very sensitive. So how do we factor in that one? Secondly, there is an agenda for universal health coverage. Now, how is this digital transformation going to cater to whatever efforts that the government is putting to make sure that everybody has healthcare coverage? Thank you.
So, Eric, can you do the first question, please, about security? And Dr. Seif and Dr. Magembe, even Dr. Seif, please, on the second question.
Good evening. I have one question and a comment. On the question, I think one thing that I was hoping also to be captured is the black hole that is there for the private sector, how digital transformation is happening with the private sector as well, because I know that information is very important also for the government when they are making different decisions of what is happening. Because for me, I know my first point of access before I go to the hospital, I'll pass by the pharmacy. So how are we encouraging the private sector to use systems, and who is governing that so that it's aligned with the transformation that is happening in the public sector? That was the question. The comment is regarding data use culture. I think one way we can also go about it is, instead of changing the culture, is also to see how our systems are aligned to the current culture of how people are accessing information, how they share that information readily. So instead of having a system that is, we just designed it to have a report that is an annual report, why not a fiscal year report that Dr. Magembe will use for her planning, because that's how she wants the information, or if she wants it on a quarterly basis. How are we aligning, how can we leverage and look into the existing cultures and design products that are really in line with that culture, so that it's not so difficult later on to start imposing people to change how they operate. If I am used to sitting in a meeting and looking at my phone and asking someone for that information, how can I access that same information when I go for supervision? I don't have to go and find my computer and log in. Instead, I could get that information right in my hands. So I think there's another stage to go in terms of how these systems are evolved to be able to fit into the culture of people, and not really invest more and more in terms of like training these people to try to change their mindsets. Thank you.
Thank you. My name is Kenneth Ogendo. I work for Dish International, and I'm glad to be here. The panel has really nailed it, painting for us a picture of how digital health systems are in terms of Tanzania. So I have two questions, and mine is to all panelists. To what extent do community health systems mainstream, or how are they mainstreamed in this journey of digital transformation? And in the journey of Tanzania, where would you say we are at? And secondly, what actions are required to accelerate community health information systems? You know, the Book 3 and Book 10 of the Tanzanian Ministry of Health, towards DHIS integration and ultimately towards universal health coverage. Thank you, and back to you.
So before the panelists forget the first question, I'd like to invite them to respond to those, and then when time allows, we'll continue. So, Eric, the aspect of security, briefly, please.
Thank you, Dr. Henry. If we go for the security question, first and foremost, we do have this document, and it's available online, Health Information System Guideline. And within that, there is a full chapter for data ownership and sharing. And within that too, we have different data sources with the custodian and access level. There's some data sources which access level is totally limited. For instance, the identification data from electronic health record. So this one is a guideline for data protection. That's number one. Number two, at the government, we are going to have an act, Data Protection Act, and it's on the bill now, and I think it will be within this year. That Data Protection Act will help us to protect our personal data. It doesn't matter from which domain, health domain, and other domain, financial and other personal information will be protected with the act. Another thing regarding the data security, all of the systems which are sensitive in terms of information, which they are collecting, they are normally on the virtual private network. at least to reduce the occurrence of being attacked. So that is another thing which we are doing as far as data security is concerned. On digital, from regional community health systems, that's a big challenge. It's a big forest, and we are working right now with Ministry of Health and TAMISEMI to see how best are we going to make sure that particular area is okay. For instance, right now we have like more than 10 community systems going around. So the issue for harmonization, the process harmonization, systems harmonization, people harmonization is very key to ensure the community systems is okay. And for instance, now there are some initiatives which we had with different partners, but somehow they were siloed. Now we are bringing them together to make sure the community system is okay. And the community systems will integrate with facility systems, being it after care or autonomous. Maybe Dr. Henda can go with those two first. Thank you.
Thank you. So I've just been told that there is another session that is being held that will continue immediately after this, so we have to finalize this session. So I would like to connect the two questions that were asked with your closing remarks. So as you are doing that, please, Dr. Magembe, can you give us your final remarks and respond to the questions that were being asked, and then Dr. Shekalagi. But before they do that, my apologies, I wanted to stay here until morning. I brought my coffee, but we've run out of time, unfortunately. And it's been a pleasure to be next to this incredible panel, also to host and moderate this session. Thank you for the presenters. Thank you for the audience. I know we want to continue talking, but we have 24 hours in a day, unfortunately. So I'm looking forward to continue this dialogue and this discussion as we move forward. So I don't want, once my leaders speak, for you to hear my voice again, so you won't hear my voice. So Dr. Magembe, your closing remarks and response to the two questions, please.
Yeah, thank you. I think Eric started by responding to some of them, but I must agree with my brother there that health data is classified data. So really the issue of security, confidentiality comes in very clearly. And I'm happy for the initiatives that are going on right now to make sure that legislation is really at its level to make sure that whatever data is being collected is safely secured. I understand there has been some pressure, people want to access data, especially partners and stuff like that. If I ask all of you here, how many people have taken a selfie of themselves and their friends this week? It could have been maybe you've taken 2-4 selfies per day. But if I ask you, how many of you did take a photo of the malaria results? Just malaria, I'm not saying HIV, malaria results. Or a pregnant test, just sharing it with your husband. The same man that you think maybe has impregnated you, it's an issue. So that tells you how sensitive this data is and the importance of us protecting that data. So the other thing is that I know with digitalization of health systems, we are generating a lot of big volumes of data. So really the issue of security is very key. So I agree, and I'm happy for all the developments that are ongoing to make sure that this data is well protected. But the other thing is we are talking about so many systems working in silos. So let me just make a plea to all of us here. I think instead of coming up with different systems in place every now and then, why don't we strengthen the existing systems? Let's just say what our needs are. Yeah, so that we have one system which is robust, so that anyone who wants data, you can extract the data from there. But when every partner comes with their own systems and their ways of doing stuff, I mean, it's really a confusion. So my plea to you, especially the primary healthcare, because I know that's the interest of everyone, let's strengthen what is there. We have our primary healthcare digitization, roadmap, and it is hosted. So I'm asking all of you, my good partners, I am your partner, whether you like or not, because whatever you want to do, you must pass by my office. And if you're not my partner, definitely, you know what will happen. So we have a costed plan, let's finance it, and I'll be more than happy when all of us actually, within that plan, they get whatever they want, but at least as a country, we stand up and say that, okay, this is our plan, this is where each one of us will take their data from, and that will ensure that our people are secure, their information is secured, and all of us are safe. With the UHC, I know my brother from the Ministry of Health, by the way, I don't have a sector, he has a sector, I'm just an implementer. Whatever he tells me, I do it as I'm told. Yeah, but with the UHC, if you go to read that bill, this has been considered, okay? You cannot, because UHC is all about quality of services, and there's no way you can achieve quality health services if digitization is not part of it. So this actually will be taken on board, and I'm sure even now when we've taken our bill to the parliament, we've used several platforms to inform the community so that they can give us their feedback, they give us their opinion, but I think in the future it will open more opportunities, yeah? So please, just be rest assured that that bill is addressing a lot of these other things. So supporting that health bill actually will also make sure that a lot of other things, especially in the digital world, that have not been addressed well in the health sector, actually that be a platform to address them. Otherwise, I think most of the issues, they were also addressed. The community component, Eric said it very well, and my brother, I know why you have asked that question. The only thing is that we've not been able to tape on those systems that are in the communities. They would give us feedback, okay? Right now, if you ask any common mind, right there, if they go to the facility and anything does not go right, they'll definitely send you a message. So these are the people that maybe would use to give us, to report to us events that happen in the community, but also to give us a feedback on how they find our services and stuff like that. So let me just promise you that we'll continue embracing that, and especially making sure that these various systems actually are talking together, and they really add value to the services that we're providing, especially getting feedback from the people that we are serving. Thank you so much, and thank you for attending our session.
So, thank you. I think most of the questions have been answered, but I think there was one question about the private facilities with the data. Now what we are doing, the Ministry of Health, regardless of the system you are coming with, we are now busy making the business process. The business process that will define, as the patient come at any facility, what are the steps, procedures that the patient will undergo. So once we have developed that, anyone comes in any system, he has to comply to that. And once you comply to that, we'll be able to capture the same information. At the moment, is the definition of the business process. That is not there. But now we are in the final stage. And why we are doing this, I know some of them people develop their own system and they for the business, and everybody wants to push. I want to sell my system. So at the moment we don't care. There are many systems that are being used, but once we have developed the system, then we can do that. I know from the primary health care facilities we recommend the dichotomies. So I think I just wanted to respond to that, but I think the rest of the answers that we've given my colleagues, I think they're okay. So my final remarks. Guys, the importance of the digital health cannot be overemphasized. This is very important. And I'm saying that we are late. I think we should now start running and not walking. This is very, very important. What I'm seeing is the issue about the hesitance and the readiness of the people to use the digital health. And this is the point of the leadership and the governance. Okay, we will say we have the dichotomies and other system, are they effectively being used? They are not effectively used. Why? Is the hesitance, the readiness of the people, the willingness of the people to use the system. We cannot run away of the digital health. Few weeks I traveled somewhere, and then when I went there, I was just told to install an app. Once I did my rapid test for the COVID. And then when you go in that country at the airport, you just open that app. And once you open it, it will blink green. And then those people just move away. So you are not using, like, producing all those papers to see whether you are vaccinated or you have done your test. It's just an app. So if you are in a queue, many people are you just show this. It's green, you go. So that it saves a lot of time.